Good morning, everybody. We are here to celebrate Pride Month, and we're going to be presenting today LGBTQ plus healthcare guidelines and shifts post-COVID-19. We welcome you, and we're very glad that we are having an amazing group of panelists today for this presentation. If you are a healthcare provider, you are entitled to also receive 4 CMEs for attending all of the presentations today. So I'll be introducing each one of our panelists as they join the podium, or the virtual podium, I will say. And this is the agenda for the day. So we're gonna have Dr. Godlock, Dr. Burrows, Dr. Nietzsche, Pride Center representing Brooklyn. We're very happy for that. And let's get started. So let me just introduce myself. I'm the moderator for the day. My name is Sandra Arevalo. I'm the Director of Community and Patient Education here at Nyack Hospital. And we are conducting not only this seminar, but different video chats every week on either Wednesday or Thursday, and some are in Spanish as well. We're trying to do it on a weekly basis at noon. So you're all welcome to join us. This is just one of the first presentations that we're doing. So now let's start our program by introducing our first speaker, Dr. Godlock. He's going to be presenting LGBTQ care guidelines and challenges. And Dr. Godlock serves as the VP and Associate Medical Director at Phelps Hospital in Northwell Health. He's also the Medical Director of the Northwell Health Physical Partners locations in Westchester County. He graduated from the University of Utah School of Medicine in 1999. He completed his family medicine resident at Swedish Family Medicine in Seattle in 2002. While practicing in New York, Dr. Godlock earned his MBA from New York University Stern School of Business in 2010. He subsequently worked for 2 years as a healthcare consultant for the Boston Consulting Group based in the New York City office. He started his current roles as Northwell Health in 2017 when he opened the LGBTQ Health Center of Excellence in Sleepy Hollow, which provides full health services for the LGBTQ community, including routine care, preventive care, PrEP, PEP, and transgender hormones in a welcoming and safe environment. So we're really thrilled to have you, Dr. Godlock. Thank you so much for attending our invitation. And now the screen is all yours, so you're ready to start your presentation.
Thank you. All right. Can everybody see my screen?
We can see it.
And can you see me as well?
And we see you. You're
perfect.
Looking very well.
Well, thank you, Sandra. And I want to give a big thanks for including me in this really important and fun presentation today. I really appreciate the work of the Pride Center there, Rockland Pride Center, and everything they've been doing to really help our community. And I'm proud to work with them and proud to be part of this today. So thank you to all for organizing and for all the work you've done. To start off, I want to talk about myself for a minute. This is a photo of my family. You can see me, I'm the person on the left of the photos you're looking on it. My husband's on the right. We have 4 kids, age 10, 8, and the twins are 6. Part of the reason I show this is to show the diversity of LGBTQ families, and also as a warning that in time of COVID, my kids are home right now. So during my presentation, you are bound to hear some kids yelling and screaming, and for all I know, they'll walk into the room and you'll see them on camera. So please pardon us this morning if you hear extra noises. I am also, as Sandra mentioned, I'm the director of our LGBT healthcare center here in Sleepy Hollow, associated with Phelps and Northwell, and I've been practicing here for years, and a lot of this talk comes from my experience in providing this care. Well, you know, there's three main things that I'm trying to accomplish in this talk, and one of the goals is talking about routine vaccination and healthcare maintenance guidelines. Another one is looking at sexual health care, including STI screening and prevention. And a third goal is understanding guidelines regarding cancer screening for the LGBTQ population. Before we start, though, I really think it's important to talk about terms. You know, I don't know everybody, all of you in the audience today, and I hope there's a wide range of people's backgrounds. I imagine there's people on this call who are much smarter than me and much more experienced than me with LGBTQ health, and I hope there's people who maybe know nothing and are just interested in learning more about this and becoming more friendly to as far as healthcare for the LGBTQ community. So because of that, I do want to make sure everybody understands the terms that we're going to be using today, so we can all be on the same page. So you'll hear the term very frequently, the acronym LGBTQ, and there's even other letters which we'll talk about. I want to make sure we're on the same page with this. So the L in LGBTQ is lesbian, and it's a sexual orientation, which is important. We'll talk about sexual orientation and we'll talk about gender identities. But it's a sexual orientation generally of a woman who is attracted to other women. Gay is another sexual orientation of men who are attracted to other men. But the term is also an umbrella term and can be used to describe women, for example, who are attracted to women. Bisexual is a person who's emotionally, sexually attracted to people of their own gender and other genders. Transgender is not an orientation, that's a gender identity. And it really is talking about someone whose gender identity differs from the sex they were assigned at birth. And then you'll see the term Q, queer, which Q can also mean queer or questioning, someone who's questioning their identity, but queer is an umbrella term, and it's used to describe people who think and consider their sexual orientation, gender identity outside of social norms. It can apply to sexual orientations and gender identity. Some people might find it offensive. As you know, if you've been around for a while, it used to be a word that was derogatory and used against people in the LGBT community, but many people have embraced it as a badge of courage and something that they think best describes who they are. Remember, there are some terminologies that are outdated. For example, homosexual really isn't used anymore. It's clinical and kind of harsh. Of course, use gay, lesbian, bisexual, LGBT. We don't use the term transvestite or transgendered. Would use transgender. And of course, sexual orientation is not a preference or a lifestyle choice. So we don't use those terms anymore that might have been used in the past. Since we're talking about the LGBT community today, let's talk about really how big that community is in the United States. So there was a study done way back in 2011, which showed that about 3.8% of the US population self-identified as LGBT. And of that, about 0.3%, or about just under 1 million, identified as transgender. The rest were LGB. Now, it's very hard to put statistics on the community. This was looking really at how people self-identify, at least the names they use to describe themselves. But in other surveys, if we ask the younger generation, these numbers go way up. And if we ask questions not just about how people identify, but what kind of behavior they engage in, such as have you had same-sex encounters, the number goes up. Some studies have shown as high as 10% possibly of the US population could fit into a category of LGBTQ. The younger generation certainly is much more fluid with these terms and much more accepting of these terms. Let's talk about some gender identities as well, so we're all on the same page as far as definitions. So we'll be talking today about transgender men, women. Let's just make sure everybody knows what we're talking about. So a transgender male, a trans man, a FTM, female to male, is a person who was assigned female at birth. So you'll hear that term a lot, assigned at birth. And that's where when we're born, we come out and the doctor or midwife or whoever is delivering us looks at our external genitalia and assigns a sex to us. And that's what's historically been done. They'll say, oh, congratulations, you have a girl, you have a boy. Of course, there are intersex and there are lots of other configurations, but that's what our culture tends to do. And so a transgender male is someone who was assigned female at birth, but knows that their gender identity is actually male. A transgender female is someone who is assigned male at birth, but understands their gender identity as female. We don't always talk about cisgender, and we should more when we talk about people. You're all hopefully aware of this term. Cis and trans are actually words that we get from chemistry, from organic chemistry, where we talk about carbon molecules, and if these other chemical groups are on the same side of the carbon chain, we call that a cis molecule. So molecules that same side. Trans as if they're on the opposite side of this carbon chain. So if someone's cis or same or on the same side, it just means that they correspond. The sex they were assigned at birth corresponds with their understood gender. For example, I'm a cis male. I was assigned male at birth, and I understand myself to be a male. A cis female is someone who is assigned female at birth and understands themselves, their gender, to be female. You'll also hear non-binary. That's another gender identity, and it's really for gender identities that these people who are non-binary are not just male or just female. They feel like those words, as society understands them now, do not describe their experience of their gender, and so they might use a term like non-binary. Gender nonconforming is a bigger term. It can talk about gender expression. It can actually refer to cis, trans, non-binary people, and you'll hear that term a lot too. I think people in society don't always understand what gender means. By knowing a person's gender, you can't make assumptions about other parts of that person. So knowing that I'm, for example, a cis male, you can't know who I'm attracted to. You can't know how I want to present or dress. If someone says they're a trans male or a trans female, you can't make assumptions whether they're on hormone therapy or whether they've had any gender affirmation surgeries. So remember, these terms don't describe everything. There's lots of different terms, and in fact, I'm going to put those terms right here kind of on one page so you can get a sense of these terms. You've probably seen this. This is in the public domain. It's called the gingerbread person, and it's a nice way to see how we break out these different characteristics about people. So identity, our brain, our gender identity is really how in our head we define our gender based on how we align with how we and our culture perceives gender. So it's, again, you could have some womenness, some manness. It's not polar extremes. You don't just be just on the women's spectrum or the man's spectrum. I think all of us, if we really pay attention to ourselves, there's a lot about me that I consider very manness when we talk about how our culture sees that. But I certainly have parts of me that I think are consistent with how our culture views women, women's gender. So everybody can have a little bit of both, and people can identify on that, on those two different spectrums. Gender identity, the way we see ourselves, is different than our sex. As you can see here, biological sex, as we talked about, is really the characteristics we're born with chromosomally, the way our genitalia look, the shape of our body. Those are biological sex. And they talk about our femaleness or maleness. And then there's gender expression, which is really how we express our gender. And that might be how we dress, especially how our society interprets what the gender norms are. How is a woman supposed to dress? How is a man supposed to dress? All of those are constructs, of course, that every society creates. And our gender expression can be along any of those feminine or masculine defined ways. Then sexual orientation, lastly, is really who we're attracted to, and that's where we get those terms. People might talk about gay or straight or bisexual or pansexual. There's all sorts of terms that can explain that. So again, I want us all on the same page today as we're talking through these different gender identity versus a person's sexual orientation and what these things mean. You know, we're talking about guidelines and challenges for healthcare. Some of the challenges I see for healthcare providers are on this screen here, and let's go through them so people can understand what these mistakes are and how we can do better in healthcare or in other areas. One is misgendering. If there's a person who's a cis male and we refer to them as trans, or vice versa, you know, this mostly affects our trans patients. If someone comes in and it's a trans female and they might not be presenting culturally as a female, people might say male. And sorry, I hear something in the background. I don't know if you hear that. Anyhow, we want to be respectful of all our patients and use the gender that they prefer, that they know they are, as the way they represent themselves. Dead naming is a term where we use a transgender person's name that they were given at birth instead of the name that they're using to define themselves. This happens in medical situations where we have medical cards that come in with ID, and that ID does not reflect the name that they use. And we should, of course, be asking them their preferred or chosen name and be using that name when we talk to them. Another mistake is confidentiality violations. When we share that a person's transgender, their gender status, with people that aren't involved in their care, for example, another staff member or a patient in the room, that's unnecessary information. Disrespectful behavior is another one, where we make a transgender person maybe feel like a medical curiosity, inviting people or med students suddenly into a room because, hey, look, here's the transgender person. It's not appropriate either. Healthcare questions or exams. When a patient comes into our offices, we, of course, should focus on why they're there. If they're there for a cold, there's no reason we have to do a genital exam on someone. And believe me, that's happened before. So we need to be very focused on why we're there. Access to restrooms. This is a big national issue, as you know, but we should create restrooms, gender-neutral restrooms at our sites where people don't have to choose a female or a male or a non-binary restroom. And then in our hospitals, we should all lobby for hospital rooms that are really based on gender identity, not on biological sex. And the best way to do that is to ask patients really what their preferences are, where they'd prefer to be run. Talking about assumptions as well, again, here's some mistakes that we make in clinical settings. Our culture is so used to saying sir or ma'am. So how can I help you, sir or ma'am? And we should cut those kind of terms off. They're really not helpful for communication. And so we can change that to just how may I help you. Also, we can avoid pronouns when we don't need to. So instead of saying things like, she's here for her appointment, we can say, the patient's here for their appointment, or the patient's here in the waiting room. For our many of our patients, this happens to me very commonly, where with my kids, I'll go into a healthcare setting and they'll say, oh, where's mom? And my kids have two fathers, right? So better ways is to say things like, where's the other parent, where's the other guardian? That's a much more inclusive, thoughtful language. Or do you have a wife? I get that question all the time from patients. And again, you can ask about, do you have a significant other, a partner? Are you in a relationship? So we should watch our language to help make our communities feel more comfortable. In our offices too, other things we can do to create a welcome environment is forms that are that allow our patients to identify their gender identity and their sexual orientation. For gender identity, most of the forms say, you know, what sex were you assigned at birth and what is your gender. And in that regard, we can see who our transgender patients are in a way that they feel more comfortable. You can also put, there should be also choices for not applicable, or do not want to answer. Nobody should be forced to answer questions if they don't feel comfortable. We should have signage in our practice about non-discrimination policies for the LGBTQ community. Right now in our waiting rooms with coronavirus, we've had to take out all our magazines, but offices should consider having out magazines, other magazines that would be more welcoming for our LGBT community. And even in the forums that we create on disease processes, we should find ways to include our LGBT community in that. All right, I want to talk for a minute about immunizations. That's one of the main learning objectives from this talk. For our LGBT community, of course, starting out, as with anyone, our community should get routine childhood and adult vaccinations per routine guidelines. That's just a given. We're all human and should follow those guidelines. But there's a few differences that you may want to put a little more focus on for our LGBT patients, and I'm highlighting them here. So one is hepatitis A and B. Remember that hepatitis A is transmitted, the infection is transmitted fecal orally. So anyone who engages in anal sex, for example, would have higher exposure to fecal particles. Anyone who does rimming, that's oral anal sex, would likewise be in that category. So those people are at higher risk of hepatitis A, and therefore should definitely be vaccinated. You know, hepatitis A vaccine hasn't been out, I don't know the exact time, I think for just about 20 years now. So anyone older than 20 may not have that vaccine. It would be important to check their records, check antibodies, make sure that they've had that vaccination and have immunity against it. Hepatitis B vaccine, of course, is transferred through body fluids, and men who have sex with men, for example, are more likely in many cases to have hepatitis B than the general population. So that's another group that would want to vaccinate against hepatitis B, even check their vaccination status, make sure they have immunity, and if they don't, to vaccinate them. One term you'll see on this slide that I think is important also for us to make sure we're on the same page with is MSM. And MSM stands for men who have sex with men. This is an important term. You know, we talked earlier about sexual orientation terms like gay, for example, but that term gay, of men who are attracted to men, doesn't explain or doesn't talk about sexual behavior. There's many gay men who don't engage in anal sex, so they may not have the same risks as other men who engage in anal sex. Also, there's many people who don't, as we talked about earlier, feel like they, even though we might consider them gay based on their behavior, that's not a term they use to describe themselves. So if we just screened gay, people for certain things would miss a lot of people who say, yeah, you know, I have sex with men, but I'm not gay. I just have sex with men. So by using terms like MSM or women who have sex with women, we can identify sexual behaviors that might put someone at higher risk rather than just sexual orientations. So talking about meningitis, everybody probably knows meningitis. Bacterial meningitis is a bacteria that causes an infection of our brain. That's meningitis, and it can be quickly fatal. People can die within 24 or 48 hours of contracting this bacterial infection. And what we found in New York City back in 2012 is a cluster suddenly of men who were having sex with other men who started getting meningitis and dying, especially in our HIV positive population. So the city health department quickly put out a notice, an advisory, saying that that we should, as providers, start vaccinating men who have sex with men with a meningitis vaccine. And the state quickly expanded that too. The definition is kind of interesting. I didn't put on the slide, but it's really a man who has sex with another man who they've met, and it talks about how people meet, like on apps or in bars, but it's pretty much however people meet and have sex. So if they have more than one sexual partner especially, they should be vaccinated against meningitis. And that should be boosted every 5 years. So a whole bunch of people got this in 2013, and it still exists, this recommendation. So some of our patients might not have been vaccinated again since then. It might be 7 years. So this is a population you should look out for and make sure they're up to date with their meningitis shot. You wouldn't do that necessarily. This isn't for the general population. Also in 2016, this was expanded, not just to include MSM, but also transgender individuals, as you can see here on this slide. So there's two groups that you should focus on making sure they're up to date with this meningitis vaccine. Another vaccine that would be very important to the community is the HPV vaccine, Gardasil. As you know, Gardasil protects against 9 strains of HPV. We know that 2 of those strains can cause genital warts, and the other strains can cause cancer. So it's very important to be aware of this. You know, our MSM population is at higher risk. MSM can have more sexual partners, more exposure sometimes, and so therefore should be vaccinated. So, you know, if you look at the guidelines from the CDC, from ACIP, they talk about vaccinating males through age 21, but there's this special request to focus on MSM through age 26. And then for many of us in the community, we're very excited last year when ACIP expanded the age range for this vaccination up to age 45 even. So we can give it. The vaccine's been approved for up to age 45. It's clinical shared decision making, and so you can talk to your patient. You know, it's not appropriate for everybody, but certainly if you have someone who maybe has been in a long-term relationship and has broken up and they're going to be back out in the dating scene, having more sexual partners, it would be very important for them to consider this vaccine. Remember, it's protecting against cancer, and it's very effective. The last tip I'd have for vaccinations or immunizations is that, remember, transgender, there's many vaccines, live vaccines, MMR, varicella, yellow fever, that can have implications for people who are pregnant. And we would not want to give these vaccines to a person who's pregnant, and would want to be cautious with our transgender men. If they still have organs that would allow themselves to become pregnant, and if they're in a sexual relationship with a sperm-producing partner, then would certainly want to assess these transgender men with a pregnancy test before we gave these shots, so as to not create any problems with their developing fetus. The next thing I want to talk about is sexual health. So I want to talk about HIV for a minute. HIV, as we know, really first came to light in the 80s, really among the LGBT population, specifically white gay men were what we saw. Of course, it was happening everywhere in Africa. Haiti was a big population. but that's what our country seemed to see it as a disease of white men, gay men, and certainly that was the largest percent of cases early on in the epidemic. But the epidemic's changed. In Africa, for example, it's highest among heterosexuals. These are stats from 2016, so I wasn't able to find some more recent stats, but it gives you just a general sense. This first grouping talks about the rate of new HIV infections per 100,000 people, and this doesn't equal 100%. You can just see the rates for different groups, and it's still in the US disproportionately affects men, but women is a very important population that's been rising for the last few years, unfortunately. It's still, the rate is higher among Black African Americans when you compare them to, when you compare the other ethnic groups, Hispanics or Asians, Latinx community or whites. So it's very important to see that this is now starting to disproportionately affect communities of color here in the United States. Another thing to look at in the bottom part of the slide is what sexual orientations are affected. It still is predominantly men who have sex with men. Of course, we should be, as providers, clinicians, we should be looking out for all of our patients, but, and, you know, heterosexuals should be screened as much as MSM, but we still see it still tends to be in MSM populations. So with that background, we now have some really great tools to help end the epidemic, the HIV epidemic here, or slow it down substantially. One thing we have, and you've probably heard of it, is pre-exposure prophylaxis. So pre-exposure prophylaxis is the idea of giving an HIV medicine to a person who's HIV negative. That person takes that medicine every day. That medicine builds up in their body so that they have this armor, this protection. So if they do get exposed to HIV through sexual contact, then that HIV particle from their partner is killed as it enters their body before it can create a long-term chronic infection in their body. You know, since 2012, we've already had this approved by the FDA, Truvada. You know, my talks about guidelines and challenges. One of the more recent challenges is we have a second medication now that's been approved by the FDA for PrEP. It's called Descovy, and there's quite a bit of controversy about it. It's a great medicine, it works really well. That's not the controversy. The controversy is which medicine should we start someone on. As you can see from the names of the medicine, Truvada is emtricitabine and tenofovir disoproxil. Descovy has the same emtricitabine dose, the exact same medicine, but the second part of the medicine, the tenofovir, is alafenamide, which is actually a pro-drug of the other tenofovir disoproxil, meaning it goes into the body, it's cleaved by enzymes and eventually becomes the same active drug. But because it's a pro-drug, it comes sooner in the process. The manufacturer postulates that it might be safer in the sense that it might have less risk to the kidneys and less risk to bone density loss. Really, those haven't fully been substantiated. There's no compelling reason for most patients to switch them from Truvada Descovy. In fact, the New York City Department of Health a few months ago put out an advisory saying it's perfectly fine to keep your current Truvada patients on Truvada. You may want to consider switching, maybe if they have some renal or bone mass problems, but otherwise we feel Truvada is a good choice, and it may be a better cost choice for patients. We'll see how this evolves over time, and as we get more information on Descovy, we might decide that based on good hard evidence that it's a better product and safer, and we'll see how that evolves over time. But regardless, do start your patients who are at risk for HIV on PrEP so we can end this epidemic. You know, we talk about a PrEP package, which in addition to the medicine is still reinforcing things like correct condom use, safer sex practices, frequent HIV testing and testing for other STDs. And also, something that you probably have seen that we should all be aware of is this equation, U equals U. If you've seen this equation, you may not know what it means. It stands for undetectable equals untransmittable. And this is a reference to patients who are HIV positive. We know that if our HIV positive patients are on antiretroviral therapy, and if we can get their viral load levels to undetectable, that's where the U is, undetectable. If they have undetectable viral loads, meaning the amount of virus they have in their body is so suppressed that we cannot measure it, then it's so suppressed that they really cannot transmit HIV. So our patients who are suppressed and undetectable cannot transmit HIV. So the whole goal now is to make sure all of our patients who are HIV positive are on good antiretroviral therapy that has them undetectable, and by doing that, they can't spread it. So if you have serodiscordant partners or HIV partners, we want to encourage them, HIV positive people, to be on this therapy, and to reassure people that having sex with them, or reassure them that they can't spread it to their loved ones, their loved partners, if they are undetectable. We still recommend that their partner be on PrEP as an additional precaution if their PrEP partner is HIV negative. PEP is another thing that you may have heard of. That stands for post-exposure prophylaxis. So this is a concept of if you have someone who's not on PrEP, someone who has sex with a partner, and the partner does have HIV, or maybe an unknown HIV status, if our patient therefore is worried that they have unprotected sex with somebody, then we can put them on HIV medicines for 28 days, and that can block potential HIV infection from taking root in their body if they were exposed. They have to start within the first 72 hours for it to be effective. The sooner the better. If you can start it in 24 hours, that's even better, but within 72 hours. And if they take, it's a 2-drug regimen. They take Truvada, which we saw from PrEP, which is that tenofovir, emtricitabine, and then also if they take a second medicine, most people like the once-a-day dolutegravir, but there's 2 options. There's a twice-a-day medicine or once-a-day. But anyway, if they take these 2 different medicines, immediately we can hopefully prevent HIV infection in them. It's important to talk to them. Anybody who comes in for PEP, to talk to them that they may want to consider going on PrEP. It sounds like they have some risk factors clearly, and PrEP may be a good idea after they finish their course of PEP. Screening for sexually transmitted infections. Here's some common STIs that we test for in patients. I think one of the more important things to realize is when we're testing for chlamydia and gonorrhea, remember people can have chlamydia and gonorrhea of their throat, their bottom, and their urethra, their front area, whether they have a penile anatomy or vaginal front hole anatomy. They can have it at any of those 3 sites. There's no blood test for it, it's a swab test. And by testing just one site, it doesn't tell us what's going on at the other sites. So please make sure you have a discussion with your patients about what sites they use for sex, and talk to them about testing those specific sites for chlamydia and gonorrhea. In our community, it's also important for guidelines for primary care to talk to our community about tobacco use. Our community, unfortunately, the LGBT community, has a higher use of tobacco products and would want to help them quit with any sort of prescription or non-prescription modes we can do. Our community also, unfortunately, has a higher use of substances, and we'd want to screen our patients for substance use and in a non-judgmental way, talk through it and help them quit and give them resources to quit. Housing insecurity. Many of our patients, especially transgender patients, but many people from the LGBT community have housing insecurity. They're thrown out of their houses, unfortunately, by a family who rejects them, end up in the streets, homeless. As you can see, over 40% of the homeless youth are especially transgender, but LGBT. So be aware of that with our youth. And then mental health, from all the microaggressions we suffer in the LGBT community, and not even just microaggressions, from government aggression that we're seeing at this point. Our community suffers from mental health, anxiety, depression concerns. And we as providers need to screen for that and help them. There's lots of helplines for suicidality. And of course, we should have them connected with mental health workers and on medication as necessary to help our community. So I want to end my talk talking about screening, specifically for cancers. Our transgender patients, especially, are less likely to get screening for a number of things, but including especially STDs and cancers. Our transgender population tends to avoid some of these services because of known discrimination from healthcare providers, or just stigma of showing up to certain locations like a gynecological office where they might be discriminated against or might feel very uncomfortable. I want to caveat that to say before I talk about some of these different screen tests is there's not a lot of research right now. One of the things we're trying to do is get more research in this community, and so we can understand this better. So this data that I'm going to present is based on, unfortunately, a lot of really small studies, even some anecdotal, just best practice opinions by medical groups, but I think they're important now and we should focus on them. On this slide, I've listed at least three different places you can go to see some of these recommendations. So we're going to talk through a few cases. So the first case, let's talk about cardiovascular disease prevention. So here's a patient, Jennifer. She's a 56-year-old Caucasian transgender female, non-smoker. She's been on hormone replacement therapy, estrogen, spironolactone, for 10 years. We do a physical on her. She comes into my office, and you can see her blood pressure is a little bit higher than it should be. Her cholesterol, her total cholesterol, is a little bit higher than we'd like it to be. And her hemoglobin A1C for diabetes shows that she's actually non-diabetic, which is good. As you may know, the way we decide to use a cholesterol medicine in our patients nowadays is through a calculator, the ASCVD, atherosclerotic cardiovascular disease calculator. And we put in things like a person's sex, we put in their cholesterol, their blood pressure, their smoking status, and this calculator calculates a risk that the person is going to die in the next 10 years of cardiovascular disease. And if the person has a 7.5% chance of dying in the next 10 years of cardiovascular disease, we usually recommend a statin. If they have less than 7.5%, we generally say that they might not benefit from a statin. So if we put this patient in this calculator, their numbers, if we put them as a female sex, which is what they are, female gender, then their risk of dying is only 4.2%. But if we change their male gender, which they were most of their life, to the male gender, male sex, then their risk is actually above the 7.5 threshold. So this is an interesting conundrum. Would you start this person on a cholesterol medicine or not? I think when we talk through these cases, the most important thing to consider, or one of the most important things, is what has their body been experiencing as far as hormones over the course of their lifetime. And if Jennifer has only been on feminizing hormones for 10 years, but for 46 years of her life, she was on her natal masculinizing hormones, her testosterone, then one would probably argue that she probably has a risk profile at this point in her life that is closer historically to a male's profile. So in this case, one may want to use the male sex in this calculator, come up with this 10.5%, and advise the patient that their risk for heart disease is higher than it should be, and they'd be a good candidate for cholesterol medicine. Of course, this is an informed discussion we'd have with the patient talking through this, but clinicians should be aware of these discrepancies and these kind of tools we use to make sure we're appropriately treating patients. I just want to point out that we don't think there's an increased risk of cardiovascular disease for trans men or trans women on our current regimens, despite some early studies that might have indicated that. Regardless of their gender identity, all patients should be screened for cardiovascular disease and encouraged to make better lifestyle choices, including smoking cessation and treating cholesterol and blood pressure. So the next thing I want to talk about is cervical cancer screening. Let's talk about this case, Frank. He's a 35-year-old Asian transgender male. He's been on hormone replacement therapy for 10 years. He has had chest reconstruction surgery, but doesn't feel it's important to have any sort of bottom surgery. He does use his front hole. That's how he names his genitalia, he does have a front hole receptive intercourse. So does he need a pap smear? He's a male, right? So obviously he does need a pap smear. You know, when we talk about screening, we talk about if a person has it, test it. So if a person has the tissue, it should be tested no matter what their gender identity is. And as we talked about, Frank still has his cervix, and he still therefore has a risk of cervical cancer. So the current guidelines for people who have cervixes is that they should be tested starting at age 21. And as you can see this, every 3 years after, if you're, depending on age range, or every 5 years if you do just an HPV test. So we should follow those guidelines for Frank, for example. Know that there can be problems doing pap smears on our trans men. Sometimes we get unsatisfactory specimens. The exam can be more painful, challenging, and should be done in a very respectful way with a smaller speculum and try to make it the best experience possible. I've even prescribed anxiety pills, benzodiazepines like Xanax for patients, so they can be much more comfortable for these tests. Another cancer that we can screen for that I want to touch base on is breast cancer, and let's use this case of Martha. Martha comes into my office. She's a 55-year-old African-American transgender female. She's been on estradiol, spironolactone since age 40, and she also had breast surgery a few years ago. So the question is, does she need a mammogram? And of course, the answer is yes, she does, because again, if a person has breast tissue, that person should absolutely have that tissue screened for breast cancer at an appropriate age. So if we look here, we know that what I think is interesting, though, is there are some guidelines about how to do that. You know, if a person just started, if a trans woman, maybe younger, and is in their 20s, you know, they wouldn't meet guidelines necessarily for screening, right? We don't usually screen. Most guidelines say age 40 at the earliest, maybe age 50. Also, if someone is age 50 and just started hormone therapy, a trans woman just started estrogen, you know, 3 months prior, they haven't built up enough breast tissue to even test at that point, and would probably still be at low risk. They'd still probably have a risk similar to a cis male. So it probably would not be something that would be particularly helpful statistically. Of course, if somebody wants the test, I'm not going to discourage them. I support them in getting that test, but we'd know in that case that the likelihood of them having breast cancer is closer to a male range than a female range based on their state in life. Also beware of our, have heightened awareness for our trans male patients who may have had chest reconstruction surgery. They may still have breast tissue, and if there's enough breast tissue, they should be tested as well. And we should still be on the lookout for cancer. We know that when those chest procedures are done, it does not remove all breast tissue, and so there is still residual tissue that needs to be examined. Colorectal cancer screening, this is just an obvious one for any sort of gender affirmation surgery. It's not generally affecting the colon, and therefore all of our patients, regardless of gender, should be screened. Unfortunately, many of our LGBT population doesn't get screened. Transgender women, for example, are less likely, some studies show, and to be screened, and sometimes that's because of just some of our transgender patients' apprehension about their anatomy and being in a medical environment and having that exposed. So there are other tests we can consider besides colonoscopies, although colonoscopies are the gold standard. We can consider other tests like stool-based tests to look for cancer risk, and that's a discussion we should have with our patients. If one of your patients just is adamantly against colonoscopy, make sure they know these other tests that can be done so they're not left out in the cold. Prostate cancer screening, let's look at this case. Roxy is a 60-year-old Caucasian transgender female. She's been on estradiol and spironolactone since age 45, so for about 15 years. She had a vaginoplasty 10 years ago, no family history of prostate cancer. As you may know, even with vaginoplasties, the prostate is almost always left in. If it's removed, it can cause problems with sexual function and also with urinary functions. The prostate's in place. So even many females who have had vaginoplasty, transgender females still have, most of them have their prostates. So does she need a prostate test, a PSA test to look for prostate cancer? So the answer is actually, the guidelines say, no, even cis men don't have to have the test. It's the test has a lot of there's a lot of concerns about it. It's can sometimes have too many false positives. So regardless, all people who have prostates should have a discussion with their doctor about the risks and benefits of doing PSA testing and should consider that test. It's very important to know, though, for cis men, we have cutoffs in the PSA test. Usually it's a cutoff of 4 or above. If their PSA is above that level, we'd consider them at risk for maybe having cancer and getting further workup. If somebody's on, if a trans woman is on estrogen, then that will lower the PSA levels. So we may need to use a lower PSA level, like of 2, some people suggest, when we'd send them in for a urologist to say they might have a higher risk of prostate cancer. All right, I know I'm out of time. My last thing I'm going to talk about before I end is bone health, osteoporosis. You know, we know that cis women as they age are at increased risk, more than cis men, of having osteoporosis. So the question is, a trans woman, a trans man, if he's lived most of his life with female hormones running through his body and only used estrogen later in life, testosterone later in life, he may have a higher risk for osteoporosis, and you'd want to really consider that person as someone who may need bone density scanning to make sure their bone density is appropriate. So use appropriate tools. There's a FRAX tool where you can estimate somebody's risk for osteoporosis, and would want to make special considerations for some of our trans patients based on their risk. All right, those are all my slides for today. Thank you for having me as part of this presentation, and in the minutes remaining, I'd be happy to open up for questions.
Great, thank you so much, Dr. Godluck. That was a great presentation. I certainly learned a lot. Like, I didn't know half of the stuff that you were presenting, so thank you so much. So we have 5 minutes from questions. Just to remind all the participants that are online with us right now, there is a Q&A feature or the chat button, so you can use either or to send your questions to Dr. Godluck. In the meantime, I don't know if some of our panelists have questions for you, so feel free to unmute if you have a question for Dr. Godluck and ask the question directly. In the meantime, I do have a question. You got me thinking about transgender women, transgender male, actually, that you were saying, you know, they still need their cervical exam and all of that. And, you know, I'm thinking all of the time we go to women's health services. to get all these tests done. So what's your intake on that? Should that name be changed at all? Like, it will look, you know, insensitive, I think, in a way, to have to go to women health services when you don't identify as a woman anymore.
Well, Sandra, you're right. I think that's really the dysphoria that this population has. It's very unnerving to go to a women's health center when you're a man and sit there in a waiting room, especially if you present as a masculine person. That's a very uncomfortable place to be. Places like Callan Lord, for example, provide pap smears on site, so people can be in an area where they feel more comfortable. If doctors don't do those pap smears in their office, they can work with their gynecology groups locally. I work with my gynecological groups and give a heads up to the gynecologist on the day of the appointment. The staff are already trained, but they make sure, the doctor usually makes sure that the medical assistant they're working with that day is especially competent and aware to make that appointment as easy as possible. But you certainly highlight a place where there's not always easy solutions and where it's a very, very uncomfortable visit for our trans men.
Mm-hmm. Yeah, that's what got me thinking. Also, you were talking about the fact that there is a lot of homelessness among this community. So do you have any resources? Do you refer your patients to certain, I don't know, like projects or something like that for people to be able to get help with housing?
So, in New York City, it's interesting. I work here in the suburbs here in Sleepy Hollow. It's a suburban setting, so we don't see homelessness like it might be seen in a more urban setting like New York, where you see people sleeping on the streets. That just doesn't happen really as often. It happens sometimes in the suburbs. So it's mostly homelessness where a transgender youth or a gay youth is kicked out of their house. And oftentimes, especially in my area, there are lots of support from other friends in the area that take these kids in and help them out. But in the rare cases there aren't support, they can be in a tough place. There are lots of social services in New York City that can help these youth. And I do have some list of services that I can refer these people to get help. Callan Lord also, a lot of our presenters are from Callan Lord. They have some very robust social services too that they can make referrals to.
I'm going to just jump in.
Thank you so much.
I just want to jump in and comment on that real quickly. For providers who are here in Rockland County, the Rockland County Pride Center is kind of your go-to place, particularly for youth. We have a very robust youth program. Alex Francisco, who's on this call, is our youth services coordinator. And so we do work with unstably housed LGBTQ youth and unstably housed adults as well, to try to advocate for them to get them the resources they need here in Rockland, rather than saying, oh, ship them out to New York City. So just a local note.
Perfect. Thank you so much for the information. That's great. So let's move to our next presenter, Dr. Burrows. So if you can unmute yourself, just a reminder. And let me share my screen. So let's talk a little bit about Dr. Burrows. He's going to be presenting the overview of standards of care for the health of transsexual, transgender, and the gender non-conforming. He is a board certified endocrinologist with Highland Medical PC. He specializes in diabetes and metabolism and serves as director of endocrinology, diabetes, and metabolism for Highland Medical and Montefiore Nyack Hospital. In years prior, he was a practicing endocrinologist with Essen Medical Associates in the Bronx. He was also a Dana Street Medical Review Panel Specialist, Senior Medical Advisor for Health Power for Minorities. and editor of Health Power Men's Health Channel. Dr. Boros was both an instructor and assistant professor of medicine at Columbia University College of Physicians and Surgeons, associate clinical professor of medicine at Mount Sinai School of Medicine, chief medical officer at North General Hospital, East Orange General Hospital in East Orange, New Jersey, and St. Francis Hospital in Wilmington, Delaware. So we welcome you, Dr. Boros. We're very happy that you're here with us, especially because you're from our house. So you can start your presentation now. Thank you so much. You can now share your screen.
Okay, Sandra. Yeah, okay, can you see it? Let's see.
Not yet.
Okay.
So there is that green button. If you can just click there.
Yeah. Mm-hmm. No? Okay. No. How's that? Can you see it?
Yes,
You can see it?
made it.
Okay.
Yes.
So let's go to slideshow. How's that? We got it?
Perfect.
Okay.
Yes, we got it. We're all seeing your screen.
Thanks, Lauren. Let's see. Okay. Yeah, so I just want to thank Sandra and of course the Pride Center and all of the people who joined for the opportunity to talk a little bit about the standards of care and the health of the community. And I learned so much as well. Dr. Godlock just gave a beautiful presentation, which will really allow me to probably move. Can you hear me? Allow me to move.
We hear you.
Hello? Can you hear me
We're
okay?
listening to you.
Oh, okay, good. So, yep. Okay. So that's pretty clear. So as Dr. Godlock pointed out, the term, the LGBTQ, it's a commonly used abbreviation, but you have to break it down for reasons that he expressed. And, there are things we can learn from really using the terms properly. For example, bisexual women and lesbians are more likely to have increased risk for cigarette smoking, and gay men increased risk for human immunodeficiency virus. So I think a lot of those things come out when you really don't just use an umbrella term, but break it down. And transgender persons have a higher risk of suicide, and you need to really look at the behaviors. Distinct risks are associated with the behaviors involved. And as Dr. Godlock went through very carefully, there's a big difference between sexual orientation and sexual activity. And of course, sexual identity correlates closely, but not completely with sexual behavior. So individuals may engage in same-sex behavior, but they may not identify as lesbian, gay, or bisexual. And a lot of women who identify as lesbian previously have had sex with men, and men have had same-sex encounters, don't really consider themselves heterosexual. So don't consider themselves, they consider themselves to be heterosexual. The risk of certain infections related to sexual activity should be asked about, including their different sexual partners. So all of this, sexual orientation, sexual activity, you can't identify patients simply based on sexual orientation. It doesn't really tell the whole story. And so that's why sexual history is so important and attendant to care for the patients in a non-judgmental way, of course. And that's what should be expected in terms of questions that will be asked in the doctor's offices. Whether the patient identifies as a man or a woman is not as important as what do they consider sexual activity? What does it really mean? And there has to be a fairly detailed and confidential exploration of what sexual activity actually means. Again, Dr. Godluck went in detail differences between sexual orientation and gender identity. And of course, he pointed it out. Gender identity really is a person's inherent sense of whether they're a man or a woman or neither. And you know, orientation, on the other hand, refers to how a person identifies their physical and emotional attraction to others. And if you don't distinguish the concepts, it can lead to some difficulties in relationships and incorrect assumptions going forward, and also looking at an individual's risk for sexually transmitted diseases won't be as accurate if there's no distinction between sexual orientation and gender identity. Again, just sort of a little run through on things that you probably know very well. Sexual orientation, we've talked about. Transgender, again, is an umbrella term used to describe sort of the discordance between a person's gender identity and the cultural expectations based on their sex assigned at birth. Transsexual, again, an older term that we now replace with the many other terms that we have available that are much more accurate. And cisgender, we talked about. The gender identity and biological sex correspond. Again, gender identity, we talked about the sense of being male or female, regardless of the genotype, phenotype, or biochemical sex. Gender queer is the term, that's the Q, that describes individuals that want to be more fluid in terms of how they see themselves. And it's not a derogatory term, it's a term that allows for more flexibility. Now, one of the big things I think everyone is aware of is limitations on access to healthcare for LGBTQ people compared to the heterosexual population. And individuals who identify in the LGBTQ community experience a lot of disparities in access to healthcare compared to cisgender heterosexual people. And for example, lesbian women, and this is why the accurate categorization is important, they're less likely to receive HPV vaccine, cervical cancer screening, and mammograms. And a lot of times, men in same-sex relationships are twice as likely to have unmet medical needs. So it's really, there's really a big discrepancy and disparity in access to care for LGBT community people. So one way to limit that, as we've mentioned, as Dr. Godluck went over, is to make sure that when the patients come to your office, that they're in an environment that would promote a good feeling and make them very comfortable with the knowledge that they're going to be treated well. And that would be gender neutral types of bathrooms. It's becoming a big problem or a big question throughout all communities at this point. But certainly transgender individuals feel much more comfortable when they use a restroom that corresponds to their gender identity and expression. And then you avoid, you can't name your clinic the Men's Health Center, as we were discussing, or the Women's Health Center. You try to use gender specific. If you try to use these terms, they really don't appeal. They make people very uncomfortable when they come to your center, particularly transgender people. And you got to have good patient intake forms that use the correct pronouns, and the electronic health record, which is an area that frequently is wrong in terms of really providing patients with a comfort level when they come to the office. Now, again, Dr. Gottlieb went over a lot of these things in great detail, which was very, very informative, and which will allow us to go through them a little bit faster. But basically addressing the healthcare needs of the community, the things we want to do are screen for mental health disorders. They're very common, and look for substance abuse, offer appropriate screening services, and do anatomic screening. In other words, screen what's available, what you have, what the patient has in front of you. Immunization, promote healthy behaviors, and initiate or continue hormone therapy for transgender patients. And an area that's frequently not talked about is screening for partner violence, intimate partner violence, which does occur and is frequently kept quiet, but should not be. And it should be brought out to the open and confidence with the patient. So mental health disorders, community people are more likely to experience depression and anxiety for a lot of reasons. And presence of these is probably about a little over 1.5 times higher in the population, in the community population, than in heterosexual people. An interesting fact is that the risk of suicide in transgender people who serve in the military, that is, they know about weaponry, is about 20 times higher than that in the general population of veterans. So we should have to be aware and be sensitive to the fact that there's sexual harassment going on, or physical or sexual violence, as well as poverty, low education levels, and unemployment makes it more likely that individuals certainly will be subjected to or have the possibility of having mental health disorders. So it's very important to screen LGBTQ patients for anxiety, depression. Suicide is a big risk. They should be referred to mental health providers who are sensitive to needs. And as Lauren pointed out, Rockland County Pride Center can be very helpful in this. You might want to look at screening tools, patient health questionnaires. I'm sure many are aware of these, and they can be very useful in screening patients for depression and anxiety, which is part of the reason we want to screen for mental health disorders. Substance abuse is fairly common, can be common in transgender individuals. High rates of tobacco use, exposure to secondhand smoke and alcohol, and drug dependence. A study of transgender women in San Francisco pointed out 58% used alcohol, 43% other substances, including marijuana, methamphetamine, crack cocaine. And of course, substance abuse increases the odds of testing positive for HIV. So there should be careful questioning of LGBTQ patients about their use of substances, and counseling and assistance with cessation, wherever possible, is very, very helpful and very, very important. Then we get into addressing the healthcare needs in terms of screening. Dr. Godlock went through this very well. HPV, of course, is something that, just like heterosexual women, lesbian and bisexual women are at high risk for HPV infection. And as he pointed out, the 9 strains, some cause cervical cancer and genital warts. And it can be transmitted by skin to skin, digital genital contact, as well as penile vaginal intercourse. And some lesbian and bisexual women may have acquired HPV from previous male sexual partners or from female to female transmission. Lesbian and bisexual women should, of course, receive PAP and HIV testing according to current guidelines, as mentioned by Dr. Godlick. Of course, one has to be very sensitive in this effort and be respectful of the discomfort that it can cause patients. Some of the other sexually transmitted infections, of course, herpes simplex virus 1, herpes simplex virus 2, Trichomonas vaginalis, syphilis, hepatitis A. Dr. Godlock went through that very nicely. Hepatitis A and B. Chlamydia can be passed between female partners. And the risk varies according to sexual practices. Another important reason to explore that, what does sexual activity actually mean? And you should never assume that lesbian women are at low risk of these types of infections, because they do occur, and some screening should go on according to the guidelines, as Dr. Godlock mentioned just a short time ago. Breast cancer he talked about quite a bit, and lesbian bisexual women they tend to receive mammograms less frequently, but they may have some risk factors that increase the risk for breast cancer. And this would be things like overweight, obesity, excessive alcohol intake. We mentioned that many bisexual women or many lesbian women have problems with substance abuse, excessive alcohol intake. And this portends a risk of breast cancer, as do the other things that we mentioned, overweight and obesity. And you have to go over with the patient the risks and the benefits of mammography, and it should be offered as a regular screening service. And a big category is screening men who have sex with men. They're really at increased risk for a number of sexually transmitted infections, including, of course, HIV, syphilis, gonorrhea, chlamydia, anal HPV, and hepatitis B and C. And certainly there's a recommendation of at least annual sexual health screening, which includes screening for these disorders, and also testing, of course, for gonorrhea and chlamydia, depending on the sexual practices, which should be, of course, explored in confidence. So in awareness of a person's anatomy and sexual practices is very important in terms of looking at, in more focused detail, what should be screened. And I think again, not just using the umbrella term LGBTQ, but breaking it down into the appropriate categories is very helpful in that sense. So we have a list here of the things Dr. Godlock went over a lot of this, but we can do it quickly. Annual screening for gonorrhea, chlamydia, syphilis. Every 6 months, if they're at high risk, should MSM have it? Yes. Women who have sex with women, chlamydia certainly, and you have to, it kind of depends on the exposure and the risk that they have. Same with transgender men and women, depends on the risk exposure as to whether they should get annual screening for gonorrhea, chlamydia, syphilis. HIV, of course, every 6 months, if men who have sex with men are at higher risk, and consider women who have sex with women based on exposure and the risk that's presented, and looking at them carefully. Same with transgender men and women. It just depends on their risk. HPV vaccination should be offered up to age 26 for all categories, since it can occur. Meningococcal vaccine, Dr. Godlock talked about this, and certainly for MSM, it is definitely something that should be done. And the other groups, of course, depends on their exposure and what their risk is. Assess for immunity to hepatitis A and B, yes. Immunize if they're not immune. And again, particularly with MSM, but it should be considered in the other groups as well. And, this is where it's important to understand what sexual activity actually means. Screening for anxiety, depression, and other mental disorders, all categories, of course. We talked a little bit about that in terms of anxiety, depression, lots of reasons for that. And this is not to say that heterosexual people don't have this as well, but certainly there's a slightly increased prevalence among the community of LGBTQ patients. Substance abuse disorders, tobacco, alcohol, drug use, all categories. Risk for breast cancer and mammography, yes. In those categories, transgender depends on the anatomy, and men and women. And whether or not hormone therapy is being applied and how long it's been applied. He gave some great case reports that really explain this much more clearly. Cervical cancer, again, it's certainly something that should be considered, but it's not always comfortable, and it has to be considered in a very sensitive, non-judgmental way. And of course, with the individual who's going to do the screening should be an important part of it in terms of being sensitive to the situation. One area that's often overlooked is the risk for osteoporosis. After a long period of time on hormone suppression, the risk for osteoporosis goes up. And certainly, particularly women starting at age 65 or earlier should be looked at carefully, depending on their risk factors. And then the hormone suppression or hormone augmentation patients should definitely get looked at for osteoporosis. A baseline bone density study and appropriate therapy, if there is osteoporosis, should be initiated. This is with bisphosphonates and, of course, calcium and vitamin D supplementation. So the next point is, what about addressing the healthcare needs through hormone therapy? And those who are on it, certainly you should continue, and those who are not are certainly candidates to initiate hormone therapy in many instances. Not everyone does. For example, some individuals that don't identify with either gender may not really want to get into hormone therapy. And the two main principles, of course, of hormone therapy for transgender patients, the idea is to reduce the endogenous hormone levels and replace the associated sex characteristics and replace hormones of the preferred sex. And the doses and the formulations are very similar to those people that we see, that I see a lot of times, that have primary hypogonadism in the form of ovarian failure or testicular failure. We use similar doses for those individuals in transsexual patients. There is a concern, of course, that estrogen therapy may increase the risk of clotting, thromboembolic disease, coronary artery disease, liver dysfunction, macroprolactinemia. But a lot of these patients have additional risk factors for these events. For example, cigarette smoking. And certainly there should be an awareness that these are things that can happen, particularly if you're really outside of the doses that we use for hypogonadism. In other words, the doses are more natural or more physiologic if you just go up to the level of hypogonadism. But if you start going way beyond that, then it becomes a risk. The risk increases. So for patients that want their physical appearance to align more closely with their gender identity, hormone therapy is often very, very helpful in improving the quality of life. Clinicians should feel comfortable starting hormone therapy in patients who've been diagnosed with gender dysphoria, but not necessarily by a mental health professional. There are other ways to look at it in terms of caseworkers and social workers who know patients very well could be helpful in terms of identifying these patients. And it's probably good to have the person to have at least had some experience as a transgender or in the desired gender for some months, 3 months at least, but more likely 12 months, and then get on into the hormone replacement, the hormone therapy, with a knowledge and a feeling that this is really what the individual desires. Okay, and I think Dr. Godlick sort of touched on this a bit, but there is a sort of a timetable that's fairly universal. And patients who have recently initiated hormone therapy should be aware that there will be some gradual changes over time. Transgender women will notice a decrease in libido and spontaneous erections within the first 3 months of therapy. And of course, breast growth occurs 3 to 6 months after treatment is started. For transgender men, fat redistribution occurs during the first 6 months of treatment, but facial hair and body hair growth tends to occur a little more slowly, measured more likely in years. Maximum, say, as time goes on, 4 or 5 years. but definitely it's slower than the other changes. Amenorrhea typically occurs within about 6 months of starting hormonal therapy for transgender men. And so this is an expectation. Some transdermal estrogen preparations can minimize the likelihood of thromboembolic disease. And if an individual is going for surgery, probably they should not be getting, at least in the perioperative period, estrogen therapy. Transdermal estrogen, of course, is it may be uncomfortable for some individuals, and so it varies according to the patient's preference. You want to keep the estrogen range. These are just sort of numbers that the providers know, but patients should trust that the provider is looking to get the range of estrogen therapy. The levels should be maintained in a normal range for cisgender women of reproductive age, less than 200 picograms per milliliter. Those are just numbers, but the providers know these numbers very well. You want to suppress the testosterone level to very low levels in transgender women. Now, transgender men we see, and heterosexual men, testosterone therapy will raise the hematocrit, the red blood cell count. It can go up fairly high. So one has to really be careful with the dosage if you're getting these kinds of complications in terms of erythrocytosis. May call for a reduction in dosage or an investigation into why there is erythrocytosis and that you're not uncovering a disorder of red blood cell production. Now, both estrogen and testosterone therapy can increase insulin resistance. Fasting glucose levels occasionally, but that's usually related to the insulin resistance. And you can get an elevation in one of the blood fats, triglycerides, with estrogen preparations. And again, these are numbers, but based on ranges for cisgender people, testosterone levels in transgender men, you want somewhere between these numbers mentioned here, 320 to 1,000 nanograms per deciliter. And you have to measure it at specific intervals, usually 3-month intervals initially. And estradiol levels, again, should be suppressed to levels that are quite low, 50 nanograms per deciliter. It should be measured quarterly during the first year. And this is in order to allow changes and adjustments in the therapy, increases, decreases, if you're going outside of the ranges that are safe and considered for cisgender individuals. And then after that, probably every 6 to 12 months, once you're in a good solid range for replacement therapy, for hormonal therapy in transgender individuals, 6 to 12 months once you're stable. Getting stable though takes some adjustments, and so every 3 months early on in the process, or even less if necessary, based on results. And we talked about osteoporosis again. With hormone therapy, there's suppression of hormone levels to a great degree, estrogen and testosterone, and it can have effects on bone mineral density in transgender men and women, leading to the risk for osteoporosis. So probably an assessment, if you can, baseline risk for bone density and assessment early on in the process is important so that you can see that there is no osteoporosis starting out, or if there is, treatment should be originated for it. And people who are at low risk for fracture from osteoporosis, usually seen mostly in heterosexual women as aging goes on, and for women that have excessive use of caffeine or alcohol, or women who are not taking calcium or vitamin D supplements. The recommended screening, though, usually starts about age 60 for people who are low risk for fracture. And of course, fractures are the devastation that osteoporosis can cause that can really be prevented by screening and appropriate therapy. Serum prolactin levels can go up with hormone therapy in transgender women, and you really should be aware of that and check baseline levels, and again, at least 6 to 12 months into therapy. For those who've been receiving spironolactone, aldactone, which is a very powerful anti-androgen, you look for serum electrolytes, particularly serum potassium can go up in patients who are taking spironolactone, and the dose has to be adjusted accordingly. Within that 3 months, complete blood counts, liver function tests should be done every 3 months during the first year of therapy for transgender men, and then 1 or 2 times per year after that, every 6 to 12 months after that. But we really want to get a look at the blood count, particularly the hematocrit and the hemoglobin red blood cell count, and the LF, the liver function test, to make sure that there's no effect on hepatic function with the hormonal therapy. You have to be careful looking at the reference laboratories, because if the laboratory is not using a proper designation of the individual status, for example, you may get ranges that relate to gender rather than to the individual's sexual orientation. So you have to look at that and be sure that you're not mistaking what may be a very good and well-structured therapy for the wrong gender. But the laboratory values are very carefully, the ranges are very carefully printed, so you can always take a look at those. Now, of course, some individuals may be interested in surgery. It's certainly not going to get into surgery in any detail at all, but it will continue the transformation to the desired sex, which is what this is all about. Patients who've used hormone therapy and really been in a real life situation, some surgeons like to see at least a 12-month period of a good social transition, just to be sure that this is what's desired by the individual. And of course, a lot of this has to be covered outside of insurance, and so the individual has to be sure they understand the cost and some of the potential complications and the recovery time, and should spend a lot of time with the surgeon or his or her office staff, understanding the process. And it also is helpful to make sure that the individual is well integrated into a good family situation and work situation, and has handled interpersonal issues before getting into the surgical side of it. And not everyone is interested in surgery, but it is an option that helps continue, the transformation to the desired sex. And then the last thing I wanted to get into a little bit was screening for intimate partner violence. This is something that's kept kind of quiet, but it's certainly very real. And it refers to, of course, physical, it could be sexual or psychological harm by a current partner or former partner or a spouse. And it can occur in some relationships. And it's difficult for individuals to get help from the conventional services many times, particularly police, court system, social services. That can be very challenging for individuals who are LGBTQ because of the biases that we've talked about earlier. And of course, the physical violence really is associated with negative mental health outcomes that are pretty profound. Although the physical injuries can be painful, the negative impact of psychological impact on the survivors is really even more profound and can't be overstated. And when there is intimate partner violence, it really sort of increases the propensity towards depression and substance abuse, and some of the things that we were talking about earlier, because of the situation that the survivor is in with the intimate partner. It's really a very stressful situation, and many times there's no one to talk to about it. And of course, the general, the existing, but hopefully lessening stigmatization and discrimination just made worse by the intimate partner violence. So we need to be aware of not just the medical and mental health sequelae of intimate partner violence, but also the challenges socially and legally. And I think that places like the Pride Center here in Rockland County can really be very helpful in looking into these situations. So familiarity with the available community resources, limitations, can really help individuals affected with this intimate partner violence. And we say refer patients to LGBTQ focused resources in the community. Again, Pride Center, Rockland County Pride Center is a marvelous resource for these types of situations. And you have to really screen and have discussions about intimate partner violence really in confidence. And it can't be, the patient has to be alone with the discussion so that there can be some real disclosure and some real rapport around this very difficult problem. I think that's pretty much all I had to say today. And I thank you for the opportunity to chat a few minutes with you. I'll turn it back over to Sandra.
Thank you, Dr. Boros, for a very interesting presentation. Let me just tell all of our participants in the call, if you have any questions, feel free to write them either using the Q&A or chat boxes. In the meantime, if our panelists have any questions for Dr. Boros, feel free to unmute yourselves and ask questions. We have a few minutes. I would like to do questions for about 5 to 7 minutes. That way we can have a 5-minute break before our next presenter. So in the meantime, Dr. Boros, I was learning a lot about the hormone replacement therapy. That sounded very interesting to me. And I was wondering, are there any physical and emotional side effects worth considering before you decide to get the hormone replacement therapy?
Yeah, that's a good question, Sandra. A lot of times, some people require a letter from a psychiatrist or a psychologist assuring that the individual is stable enough to undergo hormone replacement therapy. But in reality, it's really a matter of knowing that this is what the individual wants and that they feel that they want to proceed and go forward with more intensive gender transformation. And it's really, there's no real requirement for a psychologist letter, although it is good if you have that. But social workers who know the patient very well can also attest to their desire for a transformation. And you can get started with hormone replacement therapy.
Okay, so I was thinking about something like it could give the side effects of increased risk for diabetes or hypertension or things of that nature. Is there anything like that, or is it the same as for the rest of the population?
Right. The main thing is to make sure that you're not getting problems with the blood count, increased blood count problems. Diabetes, no, almost never. Lipid disorders, yes. Sometimes the cholesterol can go up, but all of those things can be dealt with, with conventional therapy. And there are no real, well, I think obesity, maybe metabolic syndrome are things that should be dealt with, but those are things that can be treated in conventional ways. So it really should not stop the move towards hormone therapy if the patient really wants it.
Okay, and we've been getting some questions from our attendees. One of them is, do you find that medications are covered by health insurance?
It's a mixed bag, yeah. Most of them are, depending on the insurance, of course.
Okay. Next question. What about poverty?
I'm gonna just pop in real quick on the insurance question because there's been a number of legal changes swirling around nationally. There was some movement from the federal government saying transgender care is not covered under insurance, but here in New York State, there are very robust protections. If you're finding that your patient's care is not being covered, there may be some legal recourse that person has because there are really strong legal protections here in New York that transgender care should be covered by insurance, despite any info to the contrary from the federal government.
That's good information to share with the community. Also, Dr. Boros, what is the youngest patient you treat, and what about poverty blocking?
Yeah, the youngest patient that you treat depends on what the resources are. For example, I'm an endocrinologist, and I tend to treat patients within an age range that's comfortable for me in general. So I would say for me, I probably below 16, I don't like to go as much because I don't feel I have the services that these individuals need for their general health care. So if there is a pediatric endocrinologist available, then that would probably be a better option. On the other hand, it doesn't have to be an endocrinologist. It could be a well-trained physician in many categories, primary care. So the next thought is being sure that the individual is now in the category of, say, an emancipated minor that can make decisions on their own without the supervision of their parents. If you can't get at least to that level, it's very difficult to get started. And your other question, Sandra, was whether or not
Poverty blocking,
oh,
maybe?
yeah, poverty. Yeah, certainly that's a tough one, and it just depends on whether the providers are willing to make allowances and take the patient on as much as possible, or for example, in the hospital setting, we have been able to help individuals by using some of the hospital resources. And in a lot of the centers, there's some help available, but it is a concern in terms of poverty. But there are ways around it if you really have a good community service and good community resources.
Yes, thank you. Now we have a comment from one of our attendees. They say the Center for Safety and Change offers professional training on intimate partner violence and sexual violence, including how to screen. Their phone number, if you guys please write this down, is 845-634-3344. Again, 845-634-3344, or you can email Rowan at centersc.org. That's ROWAN at CENTERSC.org. I think that's all we have. It says Rockland Center for Safety and Change is the sole victim service provider. Their 24-hour confidential hotline. And I think I saw something else from there. And they also have a text line and online chat feature from 9 a.m. to 11 p.m. Monday through Friday. You can access their website at centerforsafetyandchange.org. And if you wanna chat, use the chat feature, you go to centerforsafetyandchange.org/text. Thank you so much for that information. That's very helpful to the community. Okay, so we're just gonna pause for 5 minutes. We'll be back at 10 a.m. sharp with our next speaker, Dr. Peter Mitcher and Miss Christine Smooth from Callen-Lorde. So hang in there, coffee break. Thank you. Zoom recording here. Okay. So I was saying Dr. Mitcher, he was Chief Resident and Faculty Development Fellow at the Montefiore Department of Family Medicine from 1995 to 1999 and one of the founders of the Bronx Community Pride Center. Through 2013, he worked at Montefiore in South Bronx FQHC, developing programs in HIV and transgender care. He served on the New York, New Jersey board of AA-HIV-M from 2003 to 2006 and was secretary from 2004 to 2006. Dr. Mitcher worked on the AIDS Institute Mental Health Guidelines Committee, chairs the AIDS Institute Quality Advisory Committee and HIV, HCV, STD, QI subcommittee for Chicanas. He's gonna be co-presenting with Christina Smooth-Lowers. She has been the Chief Operations Officer at Callen-Lorde Community Health Center since January 2014. With over 20 years of healthcare operational experience, she has been responsible for various aspects of administrative management, program development, community engagement efforts, and regulatory compliance. During her time at Callen Lorde, she has facilitated the opening of 2 expansion locations in the Bronx in 2016 and recently in Brooklyn in March of this year, transforming Callen Lorde into a healthcare network, providing LGBTQ competent care with sites in 3 boroughs across New York City. Prior to joining Callen Lorde, Mrs. Mood worked as the Director of Administrative Services at Montefiore South Bronx Health Center for Children and Families and the Center for Child Health and Resiliency, the United Cerebral Palsy of New York City as the Director of Health Services Administration at Community Healthcare Network, and Bronx Lebanon Hospital. She's well-versed in the operational aspects of community healthcare. So thank you so much to both of you for joining us today. You know that I'm very honored and happy to have you here and be able to see you and learn from you everything I can. So please feel free to share the screen. Perfect, you're on.
Great, thank you so much, Sandra. I am Peter Meacher, as Sandra said. My pronouns are he and him. And I want to really thank everyone for inviting us to join you today. And I'll have Christine introduce herself briefly when she starts her part of the presentation shortly. So there are no disclosures. The agenda is as laid out. We're going to talk a little about Callen Lorde, build on some of the things that have already been discussed concerning LGBT people in healthcare, and talk about how we can transform our practices to better engage this community. And then I'd also like to reflect a little on how COVID has really changed everything. So we've heard about some of the health disparities observed for LGBT folk, and I'll review some of these. We'll look at how we can reverse them and think about how we might do this in a post-COVID world. If you think that this doesn't really apply to you or your practice, I'd like you to just reconsider that. You know, an average primary care provider has, say, 2,000 patients. And whilst in that mix, they probably are aware of LGB patients, they may not be able to think of 10 to 20 transgender or gender non-binary patients in their 2,000. But population data says that they should be able to do that. So if you are a primary care provider and you have 2,000 patients, you should expect that somewhere between 10 and 20 of those patients will identify as TGNB. So if they're not apparent to you, that is a reflection of either them avoiding healthcare altogether or perhaps not revealing themselves to you. So clearly, you know, there's things that can be done to change that, and we'll talk about some of those today. So a little background about Callen Lorde. Callen Lorde is 50 years old this year. We trace our roots back to the Stonewall riots. That was out of which came several community-based organizations, primarily offering sexual health services to the gay male population, although that quickly broadened to include others in the LGBT umbrella. These CBOs galvanized during the AIDS crisis of the 80s and moved into what is now the LGBT Community Center in Chelsea in Manhattan. I strongly recommend you visit if you haven't. It's on 13th Street, right by the 2 train, very easy to get to. And if you go to the second floor there, you will see a small room that is preserved with incredible Keith Haring murals on it. Really worth checking out. But that was where Callen Lorde first practiced, in a derelict building that was owned by the city, in the early 90s. We moved into our current main site in Chelsea in 1998. And I think the history of our organization is so important to understand the work we do, because our staff are incredibly mission driven. And, you know, Callan Lord is a wonderful place to work. It's not an easy place to work. It is not an easy job. And everyone who works there is really there because they want to be there. And it's really remarkable to work in an organization where every member of staff is very, very mission driven. I got to tell you, being in management, it presents its own challenges, but those are very welcome challenges, because everyone is very impassioned about the work they do and feels very strongly about everything we do at Callan. So I'll hand it over to Christine to talk a little about our current state of play.
Good morning, everyone. My name is Christine Smoot-Lowers, and I'm the Chief Operating Officer at Callan Lord, and my pronouns are she and her, and I am excited about being here with all of you today. So I'm going to talk to you a little bit about some of the demographics of Callan Lord. So Callan Lord is a healthcare network comprised of 4 ambulatory care locations. 2 in Manhattan, 1 in the Bronx, and our latest location is Brooklyn, which opened up in actually June of 2020 as of delays as a result of COVID. We are considered a magnet facility because many of our patients come from various boroughs throughout the city and out of state. This is a little different from many of the other federally qualified health centers where their patient base comes directly from the surrounding areas. And because of the level of specialized care and the environments we created, we do draw patients from throughout the city. In the previous year, if you just take a note to the right of the slide, we served over 17,000 unique patients and provided over 114,000 visits. And our patients' ethnic and racial breakdown is indicated below. So the gender and age of our patients self-identify their gender identity, and our population is 54% male, which is very different from many other health centers, which are primarily utilized by 2/3 women and children. The primary age group of our patients are within the 25 to 39 age range, and we also have an adolescent health program called the Health Outreach to Teen Program, HOT, which represents 1% of our patient population. Our insurance types are relatively evenly distributed between private and public insurance, and we have about a 27% uninsured rate, which is doubled in comparison to many health centers. This number is really based on a higher percentage of many of our patients being undocumented, unemployed, or underemployed. I'll turn this part of the presentation back to Peter Meacher.
So, sorry, this is rather a busy slide, but don't be too put off by it. I wanted to just share some external data to sort of ground us a little. This is a cohort study, median follow-up of people aged 18 years and older in a university gender clinic over a period of 30 years. It includes about 1,300 persons, some 960 trans women and 360 trans men. And what we see is that the key things that stand out as being different to the population as a whole are the rates of lung cancer. This is almost certainly related to smoking prevalence. The same may be true for heart disease. Also, when we look at HIV, suicide, and drug use, those are numbers that stand out. So again, this is looking particularly at trans and gender non-binary patients, but illustrates some of the disparities we've heard about already. Looking at HIV, again, breaking that down and looking specifically at trans-identified patients. Transgender women are 49 times more likely to be HIV infected than the general population. 49 times more likely. This represents about 20% of transgender women worldwide live with HIV, and the rates in the US are pretty similar. In fact, a little higher, if anything, at 22%. So some 22% of transgender women in the US are living with HIV. So think about that. That really tells a pretty powerful story. We also should consider intersectionality of race and ethnicity in all of this. If we break things down further, we see that the rates of HIV are even higher for racial and ethnic minority transgender women in the US. In fact, Black transgender women are 3 times more likely to be living with HIV than their white and Latina counterparts. And interestingly, all of this data and all of these numbers are broadly reflected in what we see at Callan Lord. This is an interesting study looking at community viral load rates. So looking at people living with HIV, the city of San Francisco, from their public health records, were able to look at everybody's last viral load in a calendar year and consider a number of factors that they thought might predict more likelihood of not being suppressed. In other words, not having your HIV under good control. And of all the factors listed here, and they included things such as intravenous drug use, which we might expect would predict, might less likely to be well controlled. None of those really stood out. The one thing that stood out was identifying as transgender. That would coincided with a much higher likelihood that your viral load would not be suppressed. So we might ask, what is going on here? And I like to think of it as a triad of things. I think the stress of living in our world and not being cis and straight, plus the intersectionality of other identities and attributes, living in our current society, this puts stress on people. So that stress leads to more risk-taking behavior and less preventative care. And if we combine that with a poorly trained health system that is not engaging this population, this is going to lead to poor outcomes. One example of the stress of living in a heterosexist or homo-transphobic world that directly impacts ability to access employment and healthcare is the ability of employers in many states up until last week to fire someone just because of their identity. Happily, things were changed last week, and for the first time, civil rights have been deemed to include protections for LGBT people. So whilst New York State has for some time had good protections around employment discrimination, the rest of the country hasn't. And so this is an extremely exciting development that hopefully is a step toward breaking down some of those disparities. One way I like to think of everything we've heard from our speakers prior, if we think of all the disparities, they essentially fall into 2 categories. There is the issue of access and engagement. This is about environment of care, and we can leverage change within our health systems to address this. And Sandra, one of the earlier talks, brought up the issue of cervical cancer screening being done in a women's health clinic, and the fact that for a trans man, right there, that is going to be a really off-putting barrier. So if we can, change our systems so that perhaps that clinic becomes called the cancer screening clinic instead, or some things like that. That's an example of the things we can do to change our health systems to break down these strong messages that are out there in our environment of care. In terms of risk, incidence, and prevalence, it's all about knowledge, and that's kind of why you're here today. If our health workforce is more knowledgeable about the incidence and prevalence of conditions for the LGBT population, we're going to do a better job of appropriately treating and screening and doing prevention work for people. And then, of course, there are many things that include both of the above. And one of the things I think of is STD screening, where screening is not only impacted around issues of access and engagement. People may be avoiding even coming for services because they don't feel that the healthcare facility is set up for them. But also if the person or the team taking care of them is not asking the right questions and is not educated about the type of screenings they should be doing on both levels, this is going to lead to poorer outcomes around STDs. And that's what we see in all STDs, including HIV. So if you need evidence that LGBT people avoid care, look at this. These are 3 columns, all looking at fears and concerns about accessing healthcare. And note that the green is for transgender identified people, and the other columns are for lesbian, gay, or bisexual identified people, and for HIV positive people, both groups that face stigma and discrimination. But you'll see that being transgender is, everything is even more accentuated than for others. And this is people's experiences that validate that fear and trepidation. So this slide is somewhat old, but I don't think much has changed in many places in the country and in New York State. But what about Cal and Lord? Is everything fixed there? You might like to think so, but unfortunately, whilst we try very hard, the answer is no. For example, take a look at this. This is looking at our own cervical cancer screening rates. And as you can imagine, we try really, really hard to do a good job, especially around our trans and gender non-binary population, but we still fall short. However, I would say that what we do well is we do measure everything, and all of our quality measures are broken down according to SOGI data. SOGI is sexual orientation and gender identity. So that is a lens through which we look at all of our data, and it reveals some interesting things. Here we're looking at cervical cancer screening. And what you can see is that we do a good job, regardless of sexual orientation, in screening our cis-identified women. However, so in other words, whether you're straight or lesbian, if you're a cis woman, you get screened at about the same rate. We've got room to improve that rate, but it's pretty equal. However, where we really fall short is with our trans male population, trans men who have a cervix that still need screening. And what this speaks to, I think, is that just sharing data isn't good enough. We have shared this data with our medical providers for more than 3 years and not seen an impact. So we have had to reconsider other things that we might like to do. And again, the name, you know, creating the right space to do this is one example of where the impact may be greater than just educating your staff. So I want to also thank Robbins for highlighting the decreased screening rates for colon cancer screening. If you think about what's involved in getting a colonoscopy, you can understand why someone who is transgender or gender non-binary may really think twice about going for a procedure. In our case, we don't do anything on site. This would involve going to a new office, a whole new staff, a whole new front desk, new nurses, new providers. And when it comes to the actual procedure, an anesthesiologist who they've probably not met except as they're about to be anesthetized. And then you are exposing a part of your body that you're extremely sensitive about to people you don't know. And many of our patients have had horrible, horrible experiences in the past where, you know, they are understandably really avoidant of any healthcare situation that they really don't have to go to. So one intervention we did that did yield some benefit was expanding what we were offering in terms of colon cancer screening. And I do have to point out our rates of colon cancer screening are nowhere near where we want them to be. We have seen some improvement in the last year or two, and this is a major project across the board going on. But I wanted to show this more to illustrate how being thoughtful about a particular population within your population and offering them alternatives may rebalance things a little. And you can see that the disparity between our cisgender and transgender, gender non-binary patients has leveled out a little bit here. Thinking about the external data I showed from San Francisco, this again plays out at Callen-Lorde. We see that our transgender, gender non-binary patients are, if they are HIV positive, they are less likely to be virally suppressed than their cisgender counterparts. And we have designed some programs specifically to address this and have seen some good gains, especially in the last year. Which isn't reflected on here, where we have included what we call flex care, which is a same-day primary and HIV care access. So people don't need an appointment, they can just show up and get seen, because people who are most likely to fall through the cracks often have really pressing other needs that don't fit with our sort of rigid appointment system. And we've had great success with our FlexCare program, which is a whole other presentation. But I guess the point I really want to make here is every time you look at data, ask yourself, I wonder if it's different for a subgroup such as LGBT or TGMB patients.
Our learning objectives for this portion of the presentation are designing systems to create a welcoming environment, patient registration as your first impression, and staff training. How do we create a welcoming environment for our patients? One of the most important steps is a training of all staff. This to include direct care staff and your behind-the-scenes support staff. This will help to create a consistent messaging and affirming standards of care throughout your organization. Hiring LGBTQ staff to represent the diversity of your patient population is also a very important step. As noted earlier from an earlier presenter, implementing gender-neutral bathrooms that affirm individual identity choices is really important. Host your anti-discrimination policy with your patient's Bill of Rights and responsibilities so patients are aware of your organizational standards. Create signage that reflects the diversity of your patient population. age, race, and identity. And lastly, don't take a person's pronouns for granted. He, she, they, them is all a personal choice. Be respectful. As part of our anti-discrimination policy, we cultivate an environment that affirms humanity and individuality, and we support and promote that philosophy throughout our network. We also use our signage and media campaigns to support anti-discrimination messaging and affirm spaces. And as you see to the right is one of our signs from our HOT program that we maintain in our waiting rooms that really talk about spaces being free spaces, free of hate, and affirming of these qualities that we want to promote within our entire organization for our patients. Our media and development teams have embarked on many signage and literature campaigns to reflect the faces, identity, and the needs of the community. And you can see some of the things that we've created. Focusing on gender neutral signage, pronouns, tell us about yours. We had a campaign to give out small stickies to all of our staff and patients so that you can identify what your pronoun is. So people are being aware and identifying people correctly and respectfully. These are some additional samples of various healthcare literatures and community resources that all reflect our branding and the use of our staff and patients and community in all of our literature and items that we create. How do we design systems that reinforce a welcoming environment? Just not the environment, but our systems. As a beginning step, your intake registration form sets the tone for your first encounter and should have inclusive language. Collecting SOGI data, as Dr. Mitra mentioned, sexual orientation and gender identity information to have a clear picture of your patient's identity. Review your documents and ensure the language does not take for granted everyone's gender identity is the same. Welcome community input. Encourage LGBTQ patients to participate in your community advisory boards. Ensure referral entities are also affirming. Many times we send our patients to specialty visits and we connect with the departments, we connect with the team to ensure that they demonstrate the same values that we have as an organization. And if they don't, what we do is we usually provide feedback from our patients to them and determine whether or not we continue to use them as a referral source. Additionally, on your registration form, please include space for preferred and legal name. Indicate relationship status, not marital status. Using the term partner, not spouse. Provide gender identity options, transgender or others, and sexual orientation questions. Additionally, provide additional patient resources for to support your patients. We have employed patient advocates and a navigation team to assist our patients in navigating our own complex systems and also navigating community resources. Again, utilize the community advisory boards for feedback. We have had real success with getting feedback from our community advisory board, having initiatives, doing pilots with that team as well, so that we can get feedback on our, genuine feedback on our services and how we're doing. And again, supporting departmental trainings is vital, vital. We're only as good as the messaging and how our staff are implementing that message throughout the organization. So, when the systems are not as inclusive and patients have negative experiences, what do you do? Even at Calum Lord, where we strive to provide affirming excellent care, there are things that happen. After hearing the patient concern, be as candid as possible regarding your understanding of the issue. Be as knowledgeable as possible about your organization's efforts and share the information with all staff. Sometimes initiatives start and they're on an organizational level and staff do not know what is happening. We need to ensure that we're conveying that. Encourage patients to voice their concerns. Be responsible and open to hearing their feedback. Provide updates on your websites and social media on organizational projects and improvements that you've made. And be mindful to always be respectful. And ask a person's pronoun, do not assume. Lastly, on affecting system changes, review your electronic medical record and provide feedback to your EMR company on areas of improvement. We have NextGen and we have worked with them to really be able to modify the systems to include SOGI data and other critical elements that our providers felt were vital to providing quality care. Review all your documents to ensure inclusive language. Heterosexualism is the assumption that people are all heterosexual, and that is not always the case. So being mindful of that. And when there is a challenge that is brought to our attention, have a manager, a director, or a patient experience representative follow up directly with the patient to discuss their concerns and how it will be rectified.
And before I talk about this slide, I just want to say Christine and I started together at roughly the same time, some 7 years ago. And I think one of the most effective things Christine did was change what was a disruptive patient committee into a patient support committee. And the whole angle changed from considering the upset patient who gets into some argument and causes disruption. The whole approach to how we dealt with that has radically changed. And it really is a sort of learning opportunity to figure out what didn't go right, how can we support the patient, and how can we do things better. And I think Christine has taken the organization through a whole paradigm shift that has been really impactful and is much more engaging for community than it was prior. So that might be something also to consider about your sites. If that isn't the case, it may well be already, I don't know. But anyway, on this slide, I just wanted to highlight the Human Rights LGBTQ Healthcare Equality Index. It's a useful tool to leverage improvements with systems to enable cultural competence in the workplace. Hospitals, by their very nature, are competitive, and I think they like to see themselves doing really well on this index. Montefiore Nyack has a partial score, so there's definitely room to improve there. I think this is a really good tool to use to improve systems and to use it as leverage with your leadership to promote some of the work that you're inclined to do to improve your systems. One of the crazy messes we're all dealing with is our electronic health records. Data collection is so critical, as I illustrated earlier. We all need to be able to identify our patients by their gender identity. So how they identify, not by just by their sex assigned at birth, although you need to know that as well. You also need to know their legal identity. You also need to know their identity on their insurance. All of these things are important. But what's most important is that when you or your staff are interacting with the patient, you know what the patient's gender identity is and what their preferred name is. So you really must have an easy way for all your staff to quickly know what the person's preferred pronoun is, what their preferred name is, to avoid the scenario that I remember so clearly more than a decade ago now, at the South Bronx as we were building a transgender program. You have to picture a busy waiting room in the South Bronx, a patient who is dressed and presenting as a female, and yet in the sign-in sheet there was no indication, there was just you signed in by your name, and it was assumed it was your insurance name. And so this patient in this busy waiting room was, and no fault of the person behind the front desk at that time, we hadn't done adequate training, but they called them by their insurance name, which was a very clearly male name. And in this busy waiting room, this individual dressed as a woman had to stand up and step forward. Now, you might all agree that would be really awkward, embarrassing, all of those things. But it's more than that. Transgender people are murdered at an extraordinary, a horrific rate in this city. You are in danger. You don't know who else is in that waiting room who might have had some disturbing reaction to this and, followed that person as they left the clinic. So I think it's important that we don't just think of this as an awkward situation. This is a life-threatening situation you are putting your patient in if you don't get this right. So it is imperative that you don't repeat that kind of scenario. So please remember that. Question every health facility you're in. Have they got mechanisms in place that a person can clearly define who they are, so they are going to be called up and go through their interaction with the name and pronoun that they choose to use. One of the things, many of the promotional materials you saw Christine present were the product of a photo shoot we've done at Callan Lord that was for both staff and patients. And those images, it was an extremely successful operation where we got lots of photos and used those photos in our materials, so that our health education materials, our posters, our videos all reflect the community we serve and our staff, who also, as much as we can, reflect the community we serve. That's a very powerful message to your community. It says you value them. The other thing, just to emphasize, is knowing your community resources is so important. And the story also that Christine mentioned about the pronoun stickers, that came out of our community advisory board, initially as a recommendation for staff. But then it was so successful that we rolled it out so staff have that on their name badge, but patients can use a pronoun sticker for their journey through the health center, so they can feel very respected in terms of their gender identity. So we've got a short video now just to play, if you want to go ahead with that. I think we're missing the sound.
Callan Lord strives to be a welcoming environment for all. Using the correct pronoun has the power to change the game. It's a step towards creating a supportive and respectful atmosphere. Her.
Sie.
They.
She.
Them. My pronouns are he, him, and his. And she, her, and hers.
Pronouns matter because people matter.
Pronouns are as diverse as our community. Pronouns are as fluid as gender and sexual orientation. Today my pronoun is they. Tomorrow it'll be different, and it's who I am.
The Pronouns Matter campaign is one step Cattle North is taking to continue improving the environment for all of our patients and to help get the word out that pronouns matter.
Her,
Him, she,
Hers.
he.
my pronouns are she, her, and hers, and they, them, and theirs.
Using a person's correct pronoun is a sign of respect.
Everyone deserves to be respected.
Everyone deserves to matter.
Employees wear buttons to help people around them use the correct pronouns.
Now, patients can use pronoun stickers to make sure people are using the correct pronouns. So, the next time you're Cattle Lord,
Grab a sticker and tell us your pronoun.
let the world know that your pronouns matter. And show people that they matter by using the correct pronouns, because pronouns matter. Pronouns matter.
Pronouns matter.
Pronouns matter.
Pronouns matter.
And I matter.
And there are a few other videos on our website, so I encourage you to look at those. We're just going to get back into the slideshow, and Christine will take it from there.
Thank you so much. I always enjoy watching that video. Calendar has done some amazing videos. So as Peter mentioned, please take advantage and go to our website. So I'm going to turn a little bit to how we manage after being in the midst of the COVID pandemic. We embarked on making significant changes on how our sites operated to ensure that we improved our safety standards, our environmental modifications, and social distancing standards. And I know Dr. Mitra will talk a little bit about this in more detail after me. But I just wanted to talk a little bit about what we've done to kind of improve our centers. So during this time, we closed for a short portion of time, but when we reopened our practices, we really wanted to focus on some major components. We reduced building staffing. We really wanted to ensure that we maintain just the number of staff we needed within the environment so we can really focus on creating systems to keep our patients and staff safe during the midst of the pandemic. Social distancing in all of our waiting areas, workspace, and common areas was something that we had to relook at, because usually we really tried to maximize the use of our space, and we had to really start thinking differently about how all of those common spaces were maintained. The use of HEPA filtration systems to improve our air filtration in our exam rooms, our procedure rooms, corridors, and some of the common spaces is what we also had to work on. We install safety barriers in all of our registration areas and pharmacies to try to create safety barriers for our patients and staff. And we provided PPE to all staff and maintained steady supplies. We were very fortunate during this time. We received a great deal of donations of masks and other PPE equipment so that we can make sure that our staff were properly maintained in a safe way, but also if patients needed masks, we were also able to provide that to them. Next slide. So the next slide really just demonstrates some of our signage that we created to keep our organizational branding and to ensure we had affirming gender neutral signage to make people feel educated and supported in the process. This location is our Bronx location. And as you can see to the right, this is where we had signage all on the registration area, installed plexiglass as well. And this is some of the signage. Next slide. Again, this is some of the signage that we placed throughout the site. And we really tried to focus on creating signage that was easy to read, that was affirming, and that also maintained our same branding so that patients know when we do put something out, it really is with the Calendar theme, and to really make sure all of our signage is welcoming and LGBTQ friendly. So I'm going to turn it back to Dr. Mitra, who will talk about some of the other COVID efforts.
Yes, and I'm specifically going to think forward, thinking about how going through this COVID pandemic has really changed our world forever. And initially, during the crisis, and we're still in that crisis, although we're slowly emerging, we had to really reconsider our clinical practice guidelines around things like PrEP and HIV, as well as things like diabetes and hypertension. We moved pretty well everything that would routinely be done every 3 months to up to every 6 months. So whilst PrEP guidelines are very clear that every 3 months you needed to get HIV tested, have a full panel of STDs, and at least twice yearly have renal function and other things done. We realized this was not going to be practical in the middle of a crisis when we were only seeing a very, very limited number of patients. Interestingly, with PrEP, I think a lot of people went on pause because their level of sexual activity changed. But we certainly stretched things to up to 6 months in terms of what we required in order to refill prescriptions for those practice guidelines. The other thing of consideration was patients coming to us for hormone injections. Some patients over the years had landed in a place where they were to come to us every 2 weeks for hormone injections. We always encourage people to either learn to do the injections themselves, and we had nurses dedicated to this role, or to use modalities that didn't require injections. However, we had a steady cohort of people that, for whatever reason, settled with coming to us and getting hormone injections. Clearly, this could not continue during a lockdown, and so we had to rapidly transition people to equivalent doses of hormones through other modalities. For the most part, we were successful, but unfortunately, there are a cohort of patients who are only comfortable getting injections and are not comfortable doing those injections themselves. And so I would like to think we fixed everything for everyone, but I am aware that there are some people who went without hormones for a period of time. Similarly, surgeries for TGMB patients, these were delayed, and the preparation for surgery was delayed, and so we are still catching up with that. It's very hard to balance the desperation of patients to get surgeries that they may have been waiting for a long time with ensuring quality. You have to be adequately prepared for surgery. Things like vaginoplasty, you need to ensure hair follicles are removed enough so that the surgery is going to have a good outcome. And all of that takes time. So all of these things have been on hold. In this slide, we are also considering COVID as an STD. I think from now on, whenever we are seeing people who come in for STD screening, we should consider doing COVID screening for both the nasal swab for virus as well as the antibody. Clearly, if someone is concerned they've been exposed to gonorrhea, chlamydia, or syphilis, they've had close enough contact with someone they're not usually in contact with, that they could have been exposed to COVID too. The other interesting part of the discussion is what is going to happen around STD rates. As I mentioned, some people report to us they went on pause for PrEP because they were really adhering to lockdown and were not having sex outside of maybe not having sex with anyone at all, or only having sex with their partner, different to their usual way of being. And so For those people, you might expect that the rate of STD would go down. However, other people continue to have sex with other people, and what stopped was their usual STD screening. So it remains to be seen what happens with STD rates as we emerge from this lockdown. I think there was a real sense of loss of community at Callan Lord, both for our staff and for our patients. You know, it's more than just any old workplace. I think many of our patients feel it is a community space, and many of our staff really get a sense of community from being a part of Callan Lord. The other thing we've moved on to consider is off-site labs. And we have now moved many of our, because we've stopped doing labs except in the context of a visit on-site because of space constraints. We have are now referring patients to off-site lab, patient service sites to get their labs drawn. But these are not sites that have been vetted or trained by us. So we've got work to do to make sure they are LGBT affirming in the same way that our organization is. And I don't really have time to talk about the work we did in a hotel for homeless people, but we definitely, if you do care to read a New York Times article that highlight that work, that came out about a month ago. And it was very interesting. Oh yeah, telehealth. You know, as with many sites, we have rapidly expanded our use of telehealth. We are a magnet site, so this has removed the same geographic barriers. This is not, however, our ideal. We'd prefer all patients get quality care within primary care near where they live. You know, that would be our ultimate goal. However, if patients are living in places where there are not such primary care facilities, I think we will be able to serve them in a new and different way. Telehealth does create an altered power dynamic in the patient-provider interaction. It's very different than seeing someone in your office where the power dynamic is very defined. It gives you a lot more insight to how that patient lives. The concerns are that the loss of community I mentioned before, and certainly that people in poverty have reduced their access, both through not having the hardware, not having the internet access that's needed, and also the concern I mentioned about remote lab testing. And just in closing, a couple of resources that our guidelines are on the website, a lot about how to take care of TGMB folk. I would recommend you look at the Endocrine Society for the most up-to-date hormone dosing guidelines. Ours are a little outdated now, but otherwise stand good. And then just also to highlight, Rubicon MD is a platform that we work with to do e-consults for providers who are starting out doing TGMB care, or to support people who have more complex cases that they need to run by. It's a sort of 24-hour turnaround, so it's not in the moment with the patient, but it certainly works well for most primary care situations. And that's it. I want to thank you. I think we both feel honored to be part of this group presenting, and especially to thank you, Sandra, for pulling this together. Please check out our website. As Christine mentioned, we have a new site in Brooklyn. So, you know, we've been in a really dark place for a number of months, but I do want to close with a sort of glass half full. I think there are some silver linings to this sinister period we're beginning to emerge from that is going to free up the way we do things and allow new opportunities. So thank you. And I think we have a couple of minutes for questions.
Thank you as well.
So thank you so much. This was very enlightening, and as a healthcare provider, I certainly will share this presentation and the content of this presentation with a lot of people, because we all need to be very supportive of the community, and you guys are definitely doing a very good job on that. So again, just to remind all of our participants that if you have any questions for Dr. Meacher or Mrs. Moots, you can just write them in the Q&A or chat icons, just by clicking on the icons and write your questions. I do have questions, so just a reminder, I'm the Director of Community Education here in Montefiore Nyack, and I was looking at the materials that you were showing. Is there any way we can get some of those materials to share with our community? Are they available?
Christine.
Yes, I'm sure they are. We will reach out. If you will contact us directly, and Sandra, you have our information, and connect them with our development team, and we will be able to share those resources.
Are they translated to any other languages? Are they only in English?
No, some of them are in Spanish as well.
That's wonderful. Then I also saw a picture of like a booklet or something you have. It said some surgeons list and resources. Is that list just for resources in the city, or does it list resources in any of the other boroughs?
I can speak to that. Yeah, it's throughout the city, but certainly relevant to the Nyack region. It's not so much for upstate or beyond the state. These are surgeons that we work with most. It is a dynamic list. It is, we do vet it, and we do, our goal is we want more and more resources. So it's not about creating exclusive lists, but it's about really trying to build the list and include people. So if there are people who are not on our list who should be, and you think should be included, I would love to be advised. Equally, I would want you to use our lists with that in mind, that these are, it doesn't mean that we're saying do not refer to someone who is not on this list, only that these are the people we can positively say we have had good experiences with and endorse.
Yeah, I'm sure a lot of people are going to be interested on getting their hands on that list. So I will email you to see where I can get it. Then lastly,
Sandra, that's on the website.
Oh, that's on the website, even better. Yes. Okay.
Yeah. So I'm going to jump in here real quick. If someone is a transgender person in Rockland County or the surrounding counties who needs a specialist, particularly if they are looking for a surgeon for gender affirmation surgery, please connect them with the Rockland County Pride Center. We offer patient navigation, so we assist people in navigating the very complex system that they're about to get themselves involved in. And we have a finger on the pulse of some folks locally who have, we certainly pull from that Callan Lord list is invaluable. But we certainly have a finger on the pulse of local options. I also want to lift up the hormone protocol document. Dr. Meacher, I appreciate you saying it's a little out of date. There have been a lot of changes in the diagnostic criteria and the actual clinical treatment of HRT. And so I just want to lift that document up as something that is quite up to date. And just, we want to be conscious that we are working from the latest best practices, the WPATH standard of care, other national and international documents outlining the proper medical care for transgender people. There have been some changes, particularly in diagnosis and who is a candidate for what procedures or treatments. So, yeah.
That is great information. Thanks for sharing, Lauren, because now I don't even have to worry about the list. I can just send people to you, and you will take care of it. So, and you will help patients navigate services. So that's amazing news for everyone in Brooklyn. So great. So we're gonna start our panel by Pride Center. And what I'm gonna ask you to do at this point is if each one of you can introduce yourselves. I have some slides with your bios and pictures, but I only have the bios for Alex and Lauren. So I wanna be fair, and it's more of you here. We're very honored to have all of you. So if you wanna start just giving a brief introduction of who you are, that's how we're gonna start this panel. So Diana, would you like to go first? Then Lauren, Brooke, and Alex. That's just how I have the order in my screen.
I'm sure. Hi, everybody. My name is Diana Wilkins. My pronouns are she or they. I'm the Director of Client Services at the Rockland County Pride Center. And I, myself and Brooke are here just really to listen. We really want to give platform to Lauren and Alex as they are definitely working with trans and non-binary adults and youth.
Lauren.
Oh, I'm sorry. I didn't know which order we were going in.
Sorry, I forgot
Yeah.
the order. So my name is Lauren Klein. I use he, him pronouns. I'm the coordinator of transgender and non-binary services for the Rockland Pride Center. So I work primarily with adults. I also assist youth who have needs specific to being transgender. And, you know, myself and other folks on our team have been working really closely with Nyack Hospital for a long time. And so this presentation at Sandra's organization is really the culmination of a lot of work behind the scenes to improve those systems. Like Dr. Meacher was saying, you know, we want to get people's hearts and minds, individual providers, but we need to change those systems to really impact the healthcare outcomes.
Brooke.
Hi, I'm Brooke Malloy. I use she, her pronouns. I'm the Executive Director of the Rockland County Pride Center. Just to echo what Diana's saying, we are here to get a lot of information, which has been fantastic. Thank you to Montefiore Nyack and Callan Lord and Dr. Gottluck. I've heard so many great things about you, so glad to be able to experience this in person. But yes, this is the time that, you know, we decided as an organization, we take leadership from the transgender and non-binary communities where their health is concerned. So we've been following Lauren and Alex in that. Thank you for having us.
Alex, welcome.
Thank you for having me. I'm Alex Francisco, and I use she, her pronouns. I am the coordinator of youth and young adult services at the Rockland County Pride Center. And I'm really excited to be here to hear Dr. Meacher and Dr. Gottluck and Burroughs. I've heard all such wonderful things about you all. And, you know, to better serve our communities.
Okay, so whenever you're ready to start,
Yeah, so Alex and I came up with a few questions to kind of spark some discussion. I'm assuming we're going to get a lot of questions in the Q&A from participants. So one of our first questions was, how did you get started? This is a question for everyone on the panel. How did you get started serving or, you know, focusing on LGBTQ patients?
Dr. Meacher, would you like to start?
Yes. Is the sound okay? I turned my air conditioner on, and so there's maybe a buzz, but it's okay? Okay, good. I can stay cool, and that's nice. You know, I got started, I did my residency at Montefiore at RPSM, the residency program in social medicine, all the way back in 1995. And when I was there really was nothing very much happening in the healthcare field in the Bronx around LGBT anything. And I and a group of others sort of recognized that, and I think it was 1997, we had like a health jam where we rented a space and we went up and down the Grand Concourse in the middle of the night, pasting posters up to get people to come to an LGBT health fair. And amazingly, I'm condensing the story, but we got like 300 people showed up one Saturday to an event, and we did a needs assessment. And what we found was that of the people there, about half had no sort of medical home, had no one. Well, firstly, most everyone identified under the LGBT umbrella. About half the people said they couldn't really identify any medical provider that they went to get care. And of the half that could, they were all in Manhattan. Like hardly anyone was getting their care in the Bronx. And this was despite the fact we knew, I mean, we were all LGBT and we were all working and we wanted to serve this community. But so there was this big disconnect of like this whole borough where people were either avoiding care altogether or they were going outside of their borough to get it. And so that was really what sparked me on this journey. I guess that would be my story. I think you're muted, Sandra.
Thank you. Okay, I was just saying that's a great story. I didn't know that story, so that's really cute. Dr. Godlock.
Sure. So I came out relatively later in life. I have a very religious background. I grew up in a Mormon family, and being gay wasn't something that was really acceptable. So it wasn't until I finished my residency that I came out. And when I came out, I was excited and out all the way. And I moved to New York in 2002 and started practicing. And I immediately joined a bunch of physician groups, LGBT physician groups, GLAMA, it's a national group, and local New York groups. Started networking with other doctors, and I immediately started getting panels of gay patients who felt more comfortable with a gay doctor. And as that grew, transgender patients started to come my way and started feeling more comfortable knowing that I was part of the community. And so just organically over time, my practice grew and grew, and my skills grew. You know, back then in 2002, there weren't even a lot of there were guidelines, there were groups putting out guidelines, but nothing like we have today. And it's been great over even the last 18 years that I've been practicing to see better guidelines, better visibility. It's still a problem though, you know, as much as, gosh, Dr. Mitra's group has done wonderful work in the New York City area. You know, the suburbs, we have a lot of people working hard. We have, you know, Rockland Pride Center, there's the LGBT Loft Center in Westchester County, but we don't have a lot of visible practitioners. So when I moved with my family out to Westchester County to Sleepy Hollow about 7 years ago, I was really the only out gay doctor specializing in LGBT care that I could find in the whole county. And I'm proud of that role, but sad that there's not a whole bunch of other out established LGBT centers for our community. Now, at the same time, I am an advocate of all doctors being competent to provide care for our community. There's no reason our community has to go to any one health center. They should feel comfortable going anywhere, and that's my goal, that every doctor across the United States can provide that care that all of our patients always deserve. In the meantime, until that happens, I'm proud to have a practice where people can come and at least feel comfortable and get what they need.
Thank you for sharing that. Yes, it is. We wish there were more services everywhere, but I attest to the point that you're making. Like, you don't need to be LGBTQ in order to provide good care. It should just be good care everywhere, regardless of that, you know. So, and that's kind of my story as well. Like, I used to work with Dr. Meacher, and I think that's, you know, joining him and his team, that's how I learned to be sensitive of all those issues. And as you said, Dr. Godlock, I organically grew into this as well. And here at Montefiore Nyack, we now have what we call the HEI, or the HAY committee. And it's a large group of us who have joined this committee together with the Pride Center in order to create awareness around this issue and try to do a better job. And as you might see, you know, we are just starting as baby steps, but we're getting there. This is, Rockland is a very conservative community, and it's not an easy job, but we're trying, we're getting there. Lauren or Alex?
Yeah, Alex, you had a very good question about the topic of pronouns and misgendering.
Absolutely. So misgendering is something that's common. It happens every once in a while. So my question is, when you misgender someone, how do you rectify or repair that? Because it is so serious. How do you move forward from that? It shows the person that you care, but it also shows them what your ethic is. So how do you, as service providers, handle that? And how can you also influence other service providers to do so?
Shall I can jump in there. It's a great question, and you know what, it happens despite our best intentions. And actually, it's really like anything else in medicine. It's about honesty and transparency. If you make a mistake, to just own up and say, I'm so sorry, acknowledge it, apologize. I think that's, at least that's how I think the best way to deal with when you individually mispronounce someone, which unfortunately is bound to happen at some point. And for the most part, I've always found when you're just honest and direct, and it's clear that you made a mistake, you regret it, and you want to do better next time, that's all people are looking for, I think.
I echo Peter's thoughts. I would like to think that most doctors, certainly I know Peter, for example, are well-intended. When I make those mistakes, it's not coming from a place where I am trying to maliciously hurt that person. And I know that does happen in society. There are people out there that refuse to use people's pronouns. They somehow consider it a personal point of pride to give people the pronouns they think are appropriate based on the person's presentation or whatever else. And those people are malicious. And when I don't even know what it would feel like to be a transgender person stuck in that scenario where somebody's maliciously, purposefully doing it, that must be very painful. And there's probably no way to rectify that except to remove oneself from the situation. When I have accidentally mispronounced people, I hope people realize it's coming from a place of just of an accidental slip. One way, even as a doctor, we try to have a medical record that can capture people's preferred pronouns. As you probably know, medical records don't do that very well. They weren't designed with transgender people in mind, or gender non-conforming, non-binary. So it makes it very hard. So I try before my visits, for example, to reference what the pronoun is. And as we saw from Peter's great video that he showed from Cal and Lord, pronouns change, of course, and that's understandable. They're fluid as people change over the course of their life and have different realizations and identify in different ways. So keeping our records up to date so we can use the most recent, most appropriate pronoun is very important. I try to reference that. Sometimes I'll slip. It's important, like Peter said, to just apologize and hopefully the other person understands where we're coming from. I think what's hardest in my practice is families will come in with younger kids who are transgender, and the parents the whole visit will mispronoun them because it's a new thing for them and they have a hard time, and that creates an environment that's a little bit difficult and complicated. I have to really be on the spot to help even the family get the pronouns right, and it can create hardness for everybody. But I think for providers who really care and make that accident, apologizing and moving on is the best thing to do.
Yeah, I'd have to agree. I think it's really you can't blame the front office staff. I mean, that's the usual thing is to, for all doctors, when mistakes occur, the patient thinks it's the front office staff. They always do. But you have to really, in this one, you got to take it. You got to take responsibility for it, and don't let it happen again. I mean, patients can tell. They can tell when you're really genuinely sorry that you made the mistake of being disrespectful to them. And if it happens again, it's a problem. The first time, it can happen. And also, you got to get after the office staff and make sure they don't let it happen again. The records are not always accurate. And I try, like Dr. Godlock, I try to look at, review the case before the patient comes in, so you have some idea of what's going on and, what the patient's pronouns are. And my staff has been trained, they're quite good at it, to really let me know ahead of time what the correct pronoun is to use. But those are the people that are directly involved in patient care. The administrative staff and the secretarial staff, they're not always as directly connected. So they can let it slip through. But again, this is a doctor issue. If you made the mistake, and you owe the patient the respect and a real apology. You can't blame the front staff. They don't want to hear that because they shouldn't.
One thing I might add is if you're ever in a position where perhaps you don't have a chart or something in front of you, a good strategy can be to be, hi, let's introduce ourselves. My name's Peter. I use he and him pronouns. And invite the other person to introduce themselves at that point. That normalizes the process of asking someone's pronouns if you're not sure.
I think this leads perfectly into another question that Alex was formulating before we got on the call about, well, I'll let you.
I didn't want to be rude and just cut, but thank you, Lauren. Actually, it's perfect for the next question I have. So in discussions with a lot of our community members, they've discussed this multiple times, that there will be side conversations where they will hear their misgender, or the doctor will use the proper pronouns, but the supporting staff will not. So what training or follow-up with your support staff are you currently using to treat your patients with respect?
It's in the same order.
We have the Pride Center. We have the Rockland Pride Center come over and Rockland County Pride Center with Lauren and his team and train our staff. And they really do a very thorough job at that. And then periodically, they come back and take another look and make sure that things are going as they should. If I get a complaint, you know, I'm not going to stand for it. And there's some explaining to do as to what are the issues, what further training do you need? We can't make these kinds of mistakes. It's very disrespectful and hurtful for the patients. So let's get it right. And they've been on the case. Rockland County Pride Center, they've serviced us very well.
And I just need to add to that. Also, we go to the CAL website. It's CAL. They have a lot of trainings over there. So we do those as lunch and learns for our staff a few times a year. And now for this year, we're going to have some of those trainings as well in our education tool, which is called Health Stream, to make it mandatory annually for all of our staff. So we're really taking, you know, desperate measures to make sure that everybody is receiving these trainings. And today, actually, after this meeting, we're going to start another meeting about this cultural sensitivity for all the new medical students that are coming in, and it's going to be part of our patient experience meetings and with our orientation, the orientation sessions for the new hirees. So we're really widespreading this education in a number of ways.
You know, I'd like to give some more tips to providers who are watching this panel. And one thing that can be very effective is before each session to huddle with your team, your medical assistant who's helping you, your nurse, even front desk staff, and go through your list of patients and make sure you've identified together what the patients are here for, what their pronouns are, what their preferred name is. So everybody's on the same page for that day. I find that if you prepare in advance, as we would with any patient, to get ready for their visit, that's something you should include on your checklist, is a preferred pronoun and preferred name, just as you'd be talking about what kind of services you're going to be offering them. I think that can tee it up to be successful. And as people have mentioned, you know, a lot of us belong to big organizations, and although our organizations try to give LGBT training, it doesn't always happen. There's not as much as we'd like. So when you have new staff members come on, make it a point for onboarding purposes. We oftentimes get covers or floats that come from a different office if one of our staff members call out, and it's important that those people be aware and be part of that huddle for that day to understand what's going to happen.
Thank you all so much for these insights from your practices. You know, kind of keeping in line with that, you know, as a resource to some of the folks that are in the audience, what are some of the sources that you go to keep up with, you know, the latest studies, the latest best practices in the field of LGBT healthcare? As we know, the medical field, things can change very rapidly. So what are your sources?
Dr. Mitchell?
I think probably the most useful sources for practice are around the guidelines. So WPATH is an organization that was mentioned earlier, the World Professional Association of Transgender Health. They're about to come out with a new set of guidelines. I think it's on 8. These are really practical guidelines on how to take care of transgender, gender non-binary patients based on all of the latest evidence. So I think if you were to have one go-to place, that would be for transgender health. I guess I don't really have, there's no one place I would say I go for LGBT health issues. I'm interested what other other panelists have to say about that. There's also transgender health, which is, I could send a link, which publishes a lot of the most up-to-date research on TGMB studies, but I'm interested what the other panelists have to say.
Well, you know, I would say the New York Times is not a bad source, apropos of recent events. Just reading the articles in the Times, you know, with the Supreme Court decisions and, you know, some of the issues that it covered relative to civil rights and general patient rights, I think it's rare to see the popular press come out with such specific issues. Other than that, you know, of course, you have the World Organization for Transgender Patients. That's probably one of our best sources. And then there's a number of them. This National LGBTQ Task Force on the health of the community, and of course, the Center of Excellence for Transgender Health has pretty good information. So those are pretty good.
I echo all those comments. I don't think there is just, as everybody said, there's not one repository or clearinghouse, unfortunately, that has everything. That would be nice, actually. I get a lot of my information, even from my medical group. You know, I'm a family medicine doctor. We have a journal that comes out every 2 weeks, and that tends to have every once in a while updates from the different societies' guidelines. So I'll see updates on transgender care or LGBT care. And there's some health centers around the country that put out updates as well. Like Callan Lord, there's Fenway in Boston, and UCSF in San Francisco have really good hubs where I can get information. And then, you know, there are some groups I belong to, some gay physician groups, where they circulate journals, and that's where I'll sometimes get some other information or updates.
Just out of curiosity, under the same topic, is there an LGBTQ healthcare conference the same way there is a pediatricians and cardiologists, or not at all? I'm just curious.
So GLAMA, G-L-M-A, Gay and Lesbian Medical Association, has an annual conference where physicians from across the U.S., even Canada, and the world, if they're interested, can meet for a one-week conference. And that has presenters from the LGBT community, physicians or other health professionals who give updates on their own research, on current trends. That's a very helpful panel. There's also a big conference that happens in Philadelphia every year, not during COVID. And the Philadelphia Trans Conference is a great source of information for updates and networking. And you know, they have a track there for new providers who are interested in learning more about transgender health, and you can go. It's a very inexpensive conference, and it's a great way for somebody to get their feet wet, and it's here in our local area, and a good place to go. Lastly, a lot of the big healthcare groups have annual conferences. Some have been doing it for years. Northwell, my institution, has a conference we just started last fall, our first annual transgender symposium, and that'll be happening. But other health centers have been doing those for a number of years now.
I just want
to make sure you share that information with us, with your symposium. That sounds great. Lauren?
I want to specifically lift up the Philadelphia Transgender Wellness Conference. It happens every summer. It was canceled this year due to COVID. It's something that the Pride Center has been encouraging staff from Montefiore Nyack Hospital to attend for a number of years. So this could be a really good moment when it comes back after COVID. It is local. It is, you know, a relatively inexpensive conference, and a great way for, you know, our existing providers to you know, sharpen skills, and for new providers who are interested in working more with particularly the transgender community to as Dr. Gottlieb said, get their feet wet.
I understand. Now we have a question from one of our participants. It says, as a trans person, I find that I am often misgendered with an assumed mom on the phone. Do any of the doctors address honorifics?
Yeah, thanks for bringing that up. In the presentation I gave at the start of the conference, that was one of the things that I mentioned. That type of language is outdated and simply not helpful anymore. Using those honorifics doesn't help convey additional information, and just allows for misgendering and miscommunication. So we work with our staff on that. Those are some hard habits for our culture to really eradicate. People see them as signs of respect. And so a lot of people persist using them, and that's going to take a long time to change people's patterns to avoid that kind of language.
Dr. Meecher, do you have any experience with that as well?
Yeah, no, I would totally agree. Just avoid using them.
Mm-hmm. Lauren? Alex?
If we don't have any other questions from the audience, there is a bit of a meatier topic that I was hoping we could get our three panelists, you know, to speak about. You know, the Rockland Pride Center has been working really closely with Nyack Hospital for a few years now around the issue of informed consent, and it's something that the Pride Center and the local, particularly trans community, feels very strongly would improve healthcare outcomes. The move from requiring the therapist letter to start hormones to a different model called informed consent. And so we do have 2 informed consent providers here. And so I'm just, you know, curious if we can get some dialogue happening around, you know, how did your organization start moving in that direction, or what are the benefits and the challenges that you've seen around this this different model of care?
I'm happy to respond to that. You know, I think informed consent is now the standard of care. It's endorsed by WPATH. Increasingly, it is accepted as the well, the preferred standard of care. At Calum Nord, we've always been doing it. You know, it really is about decreasing the barriers to access to care. You know, I think it is important everyone who is interested in starting hormones is in some way screened for any possible coexisting behavioral health diagnosis. But the vast majority of people do not have any coexisting behavioral health diagnosis. And as long as you're sort of doing some sort of screening, and that can be absolutely by the primary care provider. We landed on questions such as, you know, when you're seeing a new patient, to just as you would ask about prior hospitalizations for medical problems, to ask about any prior psychiatric hospitalizations, to ask about any current medications, including psychiatric medications, and to ask if someone has been engaged in behavioral health care. Not to say that any of those would exclude you from getting hormones, but it might be prudent to, you know, explore a little more about those issues. But if those are all sort of negative, you're done. You know, there's no need for that person to see. The other thing, of course, with informed consent, does have someone have capacity? Do they understand what they're asking for? So, you know, we prescribe so many medications that are so much more potentially harmful to a patient, and we don't go through all these extra steps of, you know, does someone really know what they're doing, and what about, you know. So hormones are, I think, you know, your most important task when you first meet with a transgender or gender non-binary patient is to engage them in care. And you want them to understand that you are aligned with them, that you want to support them in their gender identity. And so at Callan Lord, we actually have a process where someone will be started on hormones even at their first visit, assuming that you've had chance to, as I say, make sure that there isn't some co-founding psychiatric or behavioral health issue going on, you know, that you need to at least explore more or be aware of, because even something as simple as someone's had a sort of significant depression in the past that led to them being hospitalized, it's important to know that, because that might be someone who, as you start them on hormones do have an impact on your psychological state. And so you might want to check in with them a little more frequently to see how they're doing. The vast majority of times, the first thing people report when they start hormones is, you know, their anxiety and their psychological well-being improves, like long before any physiological changes really happen. There's a sense of wellness that somebody, in my experience, reports. So if anything, you're most likely to alleviate those symptoms, but I think it's important to be aware of them. You know, if somebody is on the spectrum of autism, I think you need to delve a little more deeply, because you want to make sure someone hasn't sort of, it's not a confusing factor in the picture. So anyway, I've talked a lot, but I think you get what I'm talking about. Yeah. Informed consent is about partnering with the patient quickly, engaging them, but you do need to screen for any coexisting behavioral health issues.
Right. Yeah, I have to agree. I really agree and echo everything that Dr. Mitra just said. He said it so well. It's really a matter of not creating more barriers to care. And as you know, Lauren, here we're trying to get into the informed consent mindset and avoid these letters from psychologists, or you have to have a psychiatrist evaluation before you get any care. And, you know, which is just another barrier that almost never helps anything. So I have to say, it was well said, Dr. Mitra. I really concur with virtually everything he said.
You know, from a physician's perspective, looking at the WPATH guidelines, you know, those are available for anyone to read. And patients may not know, but one of the things that we do as physicians is we have to establish that there's some gender dysphoria there. And there's criteria for that we look at. And that used to be done, as this conversation is talking about. Some doctors felt like a psychiatrist had to do that assessment, or a therapist. But we know if we can give some doctors some basic training, they can easily perform that series of questions to understand a person's past, their gender dysphoria, and and move beyond that quickly to get them the treatment they need. So it does, though, take training on a physician's part to understand those different concepts of what has to happen in a visit, to make sure that you're fully addressing the patient's needs, making sure everything's safe for them, so that when they give their informed consent, that we're also supporting them with all of the help they're going to possibly need during the process medically and even from a behavioral health aspect without holding up their care.
One thing I might add, and it was interesting having worked at Montefiore and now at Callen-Lorde, is at Montefiore, I talked to the legal department there, and they were very clear that I should not create any document that was an informed consent listing, you know, possible side effects of hormones, possible this, that, and the other, that I should not have a separate document, but rather I should, in my notes, include all the bullet points I talked to about the patient, you know, including stuff about future fertility and all number of things. And actually, at Callen-Lorde, we currently do use a document that we have the patient sign, but I've always favored the Montefiore approach. The reason being that this is not sort of wacky, off-label, something outside of primary care that we're doing. This is primary care, and it's in the scope of our practice, and so we don't need to create a separate consent document, but we should note all of the discussion points we had with a patient, and we talked about the pros and the cons and the risks and the benefits, and the patient, you know, had capacity to understand all this and, you know, agreed to move ahead with hormones. So I think that also needs to be a part of the process, either a document that's separate or as part of the note, acknowledging the specifics of what you reviewed with the patient prior to starting hormones.
Sandra, I think you're muted.
Yes, thanks. Thank you, Lauren. I believe you said you don't have any other questions, Alex?
Yeah, unless
okay,
Alex
so I
has
have
any other.
Okay, so I have one more question just to close. If you can just tell us, of course, without any personal details, like your most successful LGBTQ patient story. And that includes Pride Center as well, because I know that you do a lot of work with adults, with youth, and all of that. So I think it's a nice way to say goodbye, just talking about some of those stories that move our hearts and leave us with a good feeling inside of our work well done. Who would like to start?
Well, let me start. I probably have the least experience, so I'm going to jump ahead of these guys and put my little bit on the table. But I think one of the patients that I've been treating for a couple of years has become he's a transgender male, and he really likes sports. He likes basketball, and so do I. But it's gotten to a point where when he comes to the office for a visit, we end up talking about the New York Knicks for a good portion of the visit. And now it's just as if, you know, he expects that, and you really could not tell the difference between our conversation and a cis male, because he's transformed so much. And the great thing is that one day he was actually riding in a car with his mother for his telehealth visit. He tuned in while they were riding in the car, and he took the opportunity to ask me what I thought about the COVID problem and when were they going to start playing basketball again? When was the NBA going to get started again? And I, in turn, asked him, there's this 10-part 10-part program that has been put together by Michael Jordan and various networks. It's called The Last Dance. It's one of the best accounts of the Chicago Bulls when they were really champions. So I asked him if he had seen the Last Dance, and he said, "Of course I have." And he's seen all 10 episodes. So I think it was very gratifying for me to know that I've actually helped someone achieve a level that not only is he comfortable with it, but I have extreme comfort in seeing the patient. I really enjoy it. Thank you.
Beautiful. Thank you, Dr. Boros. Dr. Robbins?
You know, having been someone myself who came out as a gay man relatively later in life, I understand how hard it can be for trans patients with a gender identity that are coming out later in life. And I think some of the sweetest and most meaningful patients I've had, I can think of a number of them, are some trans women who have lived their whole life presented as a man, used, you know, male pronouns, and it just never sat well with them. And their whole life they had been hurting and in pain and misunderstood and felt so ostracized and estranged just from humanity almost. And having them finally have the courage to come to me and are ready to take that next step to really affirm who they are, and going through the process of doing hormones. And I can think of one that totally wanted to present feminine, and she just changed her whole life, and over the course of a few years was totally different. She lost some friends in the process, was estranged from some family in the process, but she became this fiercely independent, beautiful, just congruous person who would change their life later in life in such a wonderful way. And that's what really warms my heart, is to see these people really, some of these patients, just take a hold of their identity and live true, authentic lives. And it blesses them and it blesses our society. And it's such an honor to take part in those kind of changes.
Alex, would you like to go next?
Me? I think that every single person that we get to help of trans identity is kind of like a success story for us. Everyone, their journeys are all so different, but once you start going through the process of living in your own truth and your own authenticity, you know, there's a light that like literally comes out of every single person who we have been able to help. So I think all of them, every single one makes me really happy.
That's very cute. Yeah, right. Of course. Lauren?
I'll add on to what Alex says. Working with young people is really amazing. And there's, for LGBT young people, like having a space where they can be themselves and be affirmed for who they are is huge. And for trans and non-binary young people, like there's so many other pieces to the puzzle, not just the medical transition piece. You know, when they like get to choose their own name and have people around them affirm that for them consistently and routinely. You know, there's a lot of barriers. They can't all start medical transition as early as they would like. We didn't talk about care for youth. That's a whole other thing. But you know, like just the way that they blossom when they are being affirmed for who they are, with even just name and pronouns and being allowed to dress, you know, in a way that feels comfortable for them is just like Alex said, there's just like a light that comes out of them. I'm getting emotional.
Oh. Okay, Dr. Meacher.
Yeah, I think a story sticks with me from actually when I started at Callan Lord, and it's a story of contrast and of hope. You know, I was seeing patients, and I saw two patients back to back. The first was, I think, 24, 25-year-old trans guy who was coming to me from upstate New York. He was one of our patients who travels like 4 or 5 hours each way for his appointments. But he was, had fairly recently started hormone therapy. He'd finished college and was about to start veterinary school upstate. His family were fully supportive. He was, you know, totally, and there was nothing, no reason not to imagine that this guy was going to have a very full, exciting, wonderful, enriching, happy life. And so, you know, continued his testosterone and was going to see him back in 6 months. The patient right after him was a 61-year-old trans woman who was coming to start hormones. And as I walked in the room and sort of introduced her, she just sort of burst into tears and started crying. And she was overwhelmed with having sat in the waiting room and seen people who, she says, you know, this is where I should have been when I was a teenager or 20. And her life had been such a contrast. She'd been born in Texas. She'd been thrown out of her home when she was a teenager, so had lived rough for a number of years. She developed a drug problem, sold sex. When she was seeing me as a 61-year-old, she was living in a car. She had never been able to hold down any sort of job or any sort of stable job. She was actually a pretty accomplished, in her own way, artist. You know, she showed me later on some great stuff she'd done, but she'd never really had an opportunity to pursue that. And whilst, you know, at 61, she was embarking on this journey, it was just so tragic to realize that if only she had been able to get the care she should have got when she was younger, her entire life would have been just a completely different story, much more like the trans guy I was seeing right before her. And so, you know, this is incredibly important work. You are trans, you're able, if we can support people and get them what they need, you can change someone's life from their second life to the first life. And that's why we're doing what we're doing.
Yeah, that's why it's amazing to have you here and be able to have these presentations and this panel, because you know, it's care that it's really life-changing. Like healthcare in general is life-changing, but it's a very higher dimension, you know, so it's amazing to hear stories. Diana, Brooke, would you like to share something with us? I know you told me you wanted to keep pretty quiet, but maybe there is something you want to share with us. We have 3 minutes before we close our event.
I would just say whatever, I'm very moved. So I'm like, people are watching and I'm very moved. This is the most important work of my life. You know, this is it. And we believe so deeply, and we want to make sure that Montefiore and Highland Medical and all of Rockland providers, really can grab onto this moment. So, you know, we don't have that situation of that trans woman at 61 years old just because they live in Rockland and they couldn't start their life when they should have been able to. And so if we can all work together and make this, just let's do this for the sake of humanity, of ourselves and of our people and of this country and of our county. That's what needs to happen. So I want us all to stay dedicated and in touch with Dr. Burrow's office and the hospital and change policies and get this done for people. Thank you so much.
Thank you, Brooke.
I want to lift up also Dr. Burrows. Dr. Burrows, as an addition to Rockland County, before Dr. Burrows, there was one provider who was potentially seeing transgender patients, and now we have three for adults and one additional for young people, two of whom are at Nyack Hospital or Highland Medical. There's, like Brooke said, there's more work to be done, but you know, just having these providers here in Rockland is so huge. And I want to lift up something someone, I forget who it was, said this, you know, that it's a privilege to work with LGBT patients. I particularly work with trans people, and you know, there is something uniquely beautiful and valuable about our experiences and our journeys through life. So I appreciate everyone coming here and engaging on this topic. It is very moving.
Thank you, Lauren. Thank you so much. I know, I see it's coming from your heart. And I think all of us who are in this event today as speakers and panelists, we're all committed to that cause. So that's beautiful. Okay, so it's 11:59. Diana, unless you wanna let us hear your voice, you're good? Okay, so I don't even have enough words to thank you all for being here today. This was almost not done due to COVID. We were hesitating and we put it together pretty quickly, and given the circumstances, I think it went pretty well. This was recorded, so I'm gonna be sharing the recordings with all of you. I'm also gonna post it in YouTube in our new Community Education Montefiore Nyack channel. So you're gonna be famous pretty soon. And I have no words to thank you. I think you guys are doing a fantastic job. Hopefully, as Montefiore Nyack, we can step up to you and your standards, because all of you deserve these, not just for yourselves, but for the whole community, and we're here for the community. So thank you all, and we'll see you soon.